Good afternoon, everyone. Hopefully, I'm audible and the screen is visible as well. So let me know if the audio visuals are clear and if I can proceed. Can we start? Just give me a thumbs up in the chat box so we can start. Okay, great. Chalo. Now, yesterday we were talking about nose. So, first of all of those who don't know me, I'm Dr. Omkar Sangita Dilipra. Welcome back to the second part of your ENT revision session. Yesterday we have discussed about larynx, pharynx, and most of the parts of the nose. Okay. Now today we'll be starting with the remaining diseases related to your nose, and then we'll be proceeding with the most important part, that is what is ear. Okay. Chalo. Great. Now starting with the nose again. Important was yesterday we discussed about the lateral walls of the nose. Now we are going to talk about this medial wall of the nose. And we know this medial wall of the nose, which divides the nasal cavity into two halves or into two nostrils. This medial wall of nose is what is called as nasal septum. Okay. So this medial wall of the nose which is there, it is known as nasal septum. Important is this nasal septum which is there. As you can see, it is made up of three major structures. And what are these three major structures? The sky blue color one, the one I'm highlighting right now, that you can see is what is called as your septal or the quadrangular cartilage. This is what is your septal or the quadrangular cartilage, one major component. Next is this green colored bone. Okay, this green color small bone which is there. Okay, it is the second major contribution and it is known as the vomer bone. That is known as the vomer bone. And the third one, this purple color structure over here which is there, it is nothing else but the perpendicular plate of ethmoid bone. It is perpendicular plate of ethmoid bone. So these are the major three structures which will form the nasal septum or the medial wall of the nose. But if they ask you, apart from this, what are the minor contributions? So the minor contributions which are there, they are usually the crest of maxillary and palatine bones. It is usually the crest of the maxillary and the palatine bones. Okay, so that's important. Next is the rostrum of the sphenoid bone. Next is the rostrum of the sphenoid bone. Next is the nasal spine. Okay, nasal spine of maxilla. So a spine of maxillary bone which forms the septum. And next is the nasal spine of frontal bone. Okay, next is the nasal spine of frontal bone. So these are the four minor structures which will help in forming the nasal septum or the medial wall of your nasal cavity. Okay, so that's the important. Why this is important? Because as I've told you from ENT, a lot of times they might ask you questions related to the anatomy, and important is they always try to ask you which among the following is not a contribution in the nasal septum. Okay, so that's why you need to remember these things, the three major and the four minor contributions in the formation of nasal septum. Next, if I talk about this condition, what you can see over here, this is the normal septum. You can see this is straight, but on the other hand, this septum that you can see, it is deviated or it is crooked. Okay, so this is a case of DNS. What do I mean by DNS? DNS is nothing but deviated nasal septum. DNS is nothing but deviated nasal septum. It is very common condition. Yes, it is very common condition, but most of the patients are asymptomatic. Those who are symptomatic, guys, those who are symptomatic, they can have various other manifestations or various other clinical features. क्या क्या हो सकता है इन patients में? So they might develop a external nasal deformity. These patients might have a external nasal deformity. Next one, definitely this deviated part, na, definitely as you can see, if I draw this and this is my deviated nasal septum, this part you can see is wide, it is roomy, and therefore more air will go inside this roomy nasal cavity or this wide nasal cavity, and it will dry up all the mucus. And in this roomy nasal cavity, you will see a lot of dried up mucus, and that dried up mucus is what is called as crusts. Okay, so there will be a lot of crusts, usually on the patent side or on the wider side. Apart from this sharp angulation which is there now, this sharp angulation is what is called as spur, and this spur definitely can injure the blood vessels and it can lead to epistaxis in the patient. Okay, apart from this spur also can irritate the nerves, and if this spur irritates the nerves now, definitely the patient will have headache, and that condition is what is called as Sludder's neuralgia. The patient will have Sludder's neuralgia as well. Okay, apart from that, definitely on one of the sides, patent side pe, I have told you, on the open side or the wide side you will have crust, but on this closed side which is there, on this closed side definitely the patient can have nasal blockage, there will be congestion. Okay, so all of these features. And one of the important feature is on this open side, on this patent side, usually what will happen, now the inferior turbinate which is there now, it will try to compensate. As the inferior turbinate tries to compensate, it undergoes hypertrophy. There will be hypertrophy of the inferior turbinate, as you can see over here, and this gives us the characteristic appearance of a strawberry or a mulberry. So this is what is called as the strawberry or a mulberry nasal mucosa. So if they ask you strawberry or mulberry nasal mucosa, it is not nasal mass, because this is the basic difference. If they say strawberry or mulberry like nasal mucosa, then your answer should be ITH, that is inferior turbinate hypertrophy, and which is seen in conditions of deviated nasal septum. But if they say strawberry or mulberry like nasal mass, please answer me in the chat box. Then what would be your answer? If they ask you strawberry or a mulberry like nasal mass, then what is your answer? Please let me know that in the chat box. Treatment for this condition, deviated nasal septum ke liye, the treatment that we usually do is a surgery. And what is that surgery called as? So please remember, the treatment that we usually perform is a surgery. Okay, and that surgery is what is known as septoplasty. Please remember, as I've told you, what is plasty? Plasty ka matlab hota hai repair or reconstruction. So we are actually trying to repair the septum. That is what is called as septoplasty. Important is this septoplasty is a conservative surgery. We do not remove the whole septum. We only remove the deviated part of the nasal septum. That is what is done in septoplasty. And one of the complications of the septoplasty surgery can also be the synechia formation that we yesterday discussed in FES as well. Okay, synechia. Therefore, even after septoplasty, we will topically apply a drug known as mitomycin C, which will have that anti-fibroblastic action. Okay, so that's important to be remembered. Next is this one. A patient had a fist fight usually. A patient had a fist fight, or the patient had a trauma to his nose, and after which now the patient complains of nasal blockage. The patient complains of nasal blockage, and here you can see on the examination there is bilateral fluctuant nasal swellings. Okay, there are bilateral fluctuant nasal swellings. Why fluctuant? Because they contain fluid inside them. Okay, so these are bilateral fluctuant nasal swellings, please remember. And which kind of fluid is present inside these swellings? So we know after trauma definitely it will be the blood which will be present. So you can see this is actually a condition where there is a bleeding in the septum, and this is what is called as septal hematoma. So this is a case of septal hematoma. So in septal hematoma, the patient will present to you after a trauma, okay, usually after a fist fight or a blow to the nose, and after which the patient will complain of nasal blockage and these bilateral fluctuant nasal swellings. This is the image which had come earlier. This is a case of septal hematoma definitely. What is the treatment for septal hematoma? Please remember, the treatment for septal hematoma will be aspiration. Okay, it will be aspiration. We will try to aspirate these nasal swellings, or we will go for incision and drainage. Okay, we will go for incision and drainage of the septal hematoma, and followed by that we will go for a packing. Anterior nasal packing should be done. Why? Because if you do not do packing, if you do not put pressure, usually what will happen? Again there will be collection of blood, again there will be a formation of hematoma. Recurrence is very common if you do not perform a packing after the procedure. Okay, so that's the important thing. So if you have two options, one says IND, second says IND followed by packing, better answer is always IND followed by packing. Okay, so that has to be remembered. Next is this condition. What is this? Here you can see it is the nasal septum seen on nasal endoscopy, and in that you can see that there is a hole usually in the nasal septum. This hole is nothing else but the perforation. So it is a case of septal perforation. Please remember, it is a case of septal perforation definitely. And if I talk about septal perforation, what is the most common cause of septal perforation? So definitely most common cause of septal perforation will be again trauma. Why? Because if this after trauma patient develops septal hematoma, if the septal hematoma is not treated, it will get infected and the patient will form septal abscess. And if the septal abscess is not treated, further what will happen? There will be necrosis, and due to that there will be formation of a hole or a perforation in the nasal septum. Okay? So trauma is a very common cause of septal perforation. Next is, which local anesthetic can lead to septal perforation? Please let me know that in the chat box. Which local anesthetic has the capacity to cause septal perforation? Please let me know that once. Okay. Apart from this, definitely apart from trauma, other cause can be a surgery. That is also a type of trauma itself, iatrogenic trauma only. Apart from this, definitely there will be some granulomatous conditions. If there is perforation in the bony part, it is due to a condition known as syphilis. If there is perforation in the bony part, it is due to a condition known as syphilis. If there is perforation in the cartilaginous part, it is usually due to conditions like leprosy, TB or lupus. It is due to conditions like leprosy, TB or lupus. Whereas if there is perforation in both the parts, if there is perforation in bony as well as the cartilaginous part of the nasal septum, then usually the likely cause will be, answer this, very good, yes, the potent vasoconstrictor or the local anesthetic that can lead to septal perforation is definitely cocaine. Yes, because cocaine which is there now, cocaine is snorted usually via the nasal route, and that is the reason why the patient can develop septal perforation, because cocaine is a potent vasoconstrictor. If it causes extreme vasoconstriction, there will be decreased blood supply, that is ischemia, which will further cause necrosis, and finally perforation of the nasal septum will be there. Okay? Now which condition causes perforation in both the parts, bony as well as cartilaginous? That was a previous year question as well. Please let me know that. जल्दी से बता दो एक बार. Which condition causes septal perforation in both the parts? Complaint will be only a whistling sound will be there. The patient will have a whistling sound. Whenever he tries to breathe, there will be leakage of air from one nasal cavity into another. And due to that reason, there will be a whistling sound which comes. And therefore, the treatment is close the perforation. And this closure of perforation is done usually by inserting either septal buttons or septal obturators. Okay, this is usually done by inserting septal button or septal obturators. That's the important thing. If I talk about both the, yes, very good, Jai Gopal, that's important. It is due to a condition known as vaginous granulomatosis, but hopefully now all of you are quite aware that the new name for vaginous granulomatosis is granulomatosis with polyangiitis. The new name is granulomatosis with polyangiitis. Okay, so that's the same thing, vaginous granulomatosis, but as Harrison's have changed the term, therefore in the option you will find granulomatosis with polyangiitis. Okay, that's important. Next question is a female who comes to us with nasal stuffiness. Okay, that means naak bhari hui hai uski, nasal congestion is there. She comes to us with nasal stuffiness. There is merciful anosmia. That means she is not able to smell anything. She is having anosmia completely. Okay, but there is foul smell coming from her. She cannot sense that foul smell. Okay, she cannot sense that foul smell, but there's a lot of foul smell coming from her definitely. Okay, so there's a foul smell. There is nasal stuffiness. She is having merciful anosmia. This merciful anosmia can work as the keyword for your question. And the below given picture is seen on examination. What is the treatment of choice? Now, what is seen on the below given exam picture? As you can see over here, what is seen? You can see in the nasal cavity, there is a lot of dried up mucus. And I've told you, what is dried up mucus called as? It is nothing but the crust. So definitely the patient is having a lot of crust in the nasal cavity. Very good, Saichan. Yes, the diagnosis for this condition. If the patient is having a lot of crust, usually she is a female who is coming to you along with features of nasal stiffness, foul smell and merciful anosmia. Definitely the diagnosis has to be atrophic rhinitis. The diagnosis has to be atrophic rhinitis definitely. As we have seen that atrophic rhinitis is more common in females usually. Okay, the most common cause of atrophic rhinitis can be autoimmunity. Yes. Okay, it is not the infection, it is autoimmunity which is the most common cause. Other causes can be vitamin D or estrogen deficiency. It can be vitamin D or estrogen deficiency. And one more important is definitely an infection with a bacteria called as Klebsiella azene. Okay, important one is an infection with a bacteria called as Klebsiella azene. And as there is a bacterial infection known as Klebsiella azene which can lead to atrophic rhinitis, therefore atrophic rhinitis is also known as azena. Therefore, atrophic rhinitis is also called as azena. That's the important thing. What will happen over here? So, if I draw a nasal cavity over here, just remember, it will be seen in both the nostrils. I'm just comparing it over here. Okay? So, this is the normal side. Okay, these are the turbinates usually present on the lateral wall of nose. But what will happen in cases of atrophic rhinitis? There will be atrophy of the mucosa, submucosa, and even the bony parts of the turbinate. That is the reason why you will see over here. Definitely there will be atrophy of these turbinates. There will be atrophy of these turbinates, and that is the reason why you can see the nasal cavities will be spacious. The nasal cavities will be wide. They will be roomy. Therefore, there will be more amount of airflow into these nasal cavities, drying up all the mucus which is there, and that leads to formation of excessive crusts in the nasal cavity. What will happen if there is excessive crust? This excessive crust can get infected, and when it gets infected, it will release a lot of foul smell from the patient. But as definitely there is atrophy in the nasal cavity, there is atrophy of this upper part also. And what lies in the upper part of nasal cavity? I told you yesterday, it is the olfactory epithelium. Yes, therefore there is atrophy or there is damage of the olfactory epithelium also. As there is damage of the olfactory epithelium, the patient will not be able to sense any kind of smell. Okay, that is the reason why the patient is having anosmia, complete loss of sense of smell. Okay, and there will be a very foul smell coming from the patient. Very good. If I ask you the treatment of choice, very good, the answer is right. If I talk about the treatment of choice, definitely it is not a surgery. Please remember, it is not a surgery. No, it cannot be a surgery. Okay, the first line management is not a surgery. The treatment of choice is usually a alkaline nasal douching. Okay, what is the treatment of choice? It is alkaline nasal douching. So what do we do in this procedure? We usually ask the patient to prepare a solution every morning. And what is that solution? It contains 2 parts of sodium chloride, that is NaCl, 1 part of sodium biborate, and 1 part of sodium bicarbonate, that is your baking soda. She needs to make a solution out of it and take a syringe and push that solution into a nasal cavity every morning. Why? So as she pushes this solution into a nasal cavity every morning, all the crust which have been formed, they will get washed off, and there will not be any infection, and therefore there will not be any foul smell coming from the patient. Okay, so that is what is done. Treatment of choice is always alkaline nasal douching. That you need to remember. Please remember. If that fails, then definitely we can go for a surgical management. And if they ask you surgery of choice, then definitely the surgery of choice is not a Young's operation anymore. In Young's operation, what we used to do? In Young's operation, we used to close one of the nasal cavities for a span of 6 months, and then we used to do it on the other side as well for the next 6 months. But nowadays, we don't go for that conventional Young's operation. Rather, we go for a modified version of the Young's operation. Surgery of choice nowadays is not Young's, it is rather a modified Young's operation. In this, what we do? We close both the nasal cavities permanently, but partially. Okay, so permanent partial closure of both the nasal cavities is done, not a complete closure. Okay, so that's important, that you need to remember. Yes, definitely estrogen spray can also be used, because I told you one of the causes of atrophic rhinitis can also be estrogen deficiency, but that is not the first line management. Okay, that can be given alongside. Next is here, make a diagnosis of this question. He is a person who belongs to North India, usually from the state of UP or Rajasthan, and now the patient has come to me. Okay, he gives me history of what? He gives me history which is exactly similar to, he was having nasal obstruction, he was having a lot of crust, he was having foul smell, and he was having merciful anosmia. So definitely this history is exactly similar to what? This history is exactly similar to atrophic rhinitis. Okay, this history is exactly similar to atrophic rhinitis, definitely. Okay, so he was giving me a similar history of atrophic rhinitis, but now the patient comes to me. Okay, now the patient is coming to me definitely, and what is the complaint of the patient? Definitely he's having these nodules over his, external nose, and the nose has become woody hard. Okay, he is having nodules over this external nose, and the nose has become woody hard. So what is your diagnosis in this condition? What is your diagnosis? Very good, right? The diagnosis in this condition is a case known as rhinoscleroma. Now by the name itself we can understand. Scleroma is what? Scleroma is nothing but sclerosis or fibrosis of what? Of the nose. Definitely here there is fibrosis or sclerosis of the nose, due to which the nose becomes woody hard. Therefore this is also known as woody nose. Okay? Rhinoscleroma can also be called as woody nose as well. That's the important thing. What is the cause? Definitely. So please remember, the cause for this is a bacterial infection. It is a granulomatous bacterial infection, and that is nothing else but Klebsiella rhinoscleromatis. By the name itself it is evident, it is Klebsiella rhinoscleromatis. Please let me know in the chat box, if I take a biopsy from these nodules, if I take a biopsy of these nodules, what will be the histopathological features seen? What will be the histopathological features seen? Please let me know that. So remember, Klebsiella rhinoscleromatis is the cause. Definitely it is the bacteria also known as Frisch bacillus. It is also known as Frisch bacillus, which is the cause of this condition. Rhinoscleroma has 3 stages. First stage is exactly like atrophic rhinitis. Second stage is this woody nose, where there will be granulomatous infection, and third stage there will be complete fibrosis of the nose. Okay, that is called as the fibrosis stage. Now please tell me, what will be seen on the histopathological examination? So if I take a biopsy of these nodules on histopathological examination, I'll be able to see 2 important features. One are the macrophages. These macrophages will contain bacteria inside them, and these macrophages which has bacteria inside them, very good, these are known as the Miculus cells. So these will be called as the Miculus cells, whereas the other one, inclusion bodies which are seen, are known as the Russell bodies. Okay, so important 2 features will be seen on biopsy. One is called as the Miculus cells, other is known as the Russell bodies. Don't get confused with the Russell's bodies seen in cases of multiple myeloma. Those are different. Those are seen in plasma cells. Okay? So those are different. These are Russell bodies and the mercurous cells. Very good. If I talk about the treatment of choice, okay, in the condition, if I talk about the treatment in this patient, definitely as it is a bacterial infection, I'll give antibiotics to the patient, and the antibiotics which are given are definitely streptomycin should be given to the patient. Along with that, we need to give tetracycline. So streptomycin and tetracycline is the combination which is used to treat a case of rhinoscleroma. Okay. Next is this condition. I have asked you a question also. Okay, I have asked you a question as well. Please remember, rifampicin was given earlier, guys. Please remember, rifampicin can be used definitely, but the better results are usually seen with a combination of strep plus tetra. Okay, so that's the basic thing. Usually, I told you, how does this mass look like? This mass looks like a mulberry or a strawberry. So I have asked you a question earlier, like mulberry like nasal mass. Okay, mulberry like nasal mass is seen in which condition? So now this is the question. Mulberry like nasal mass किस में दिखता है? Please let me know that. What is the diagnosis in this condition? Make a spot diagnosis. Make a spot diagnosis. Mulberry like nasal mass. Very good. Very good. Very good, all of you. This condition is what is called as rhinosporidiosis. Okay. And please let me know one thing. The causative agent of this rhinosporidiosis is known as Rhinosporidium seaberi. It is known as Rhinosporidium seaberi. Let me just know that whether it is a fungus or an aquatic protozoa. Whether it is a fungus or an aquatic protozoa. So rhinosporidiosis is caused by an organism known as Rhinosporidium seaberi. And usually when the patient will get an infection, so usually this commonly is seen in the southern parts of India, usually in the state of Tamil Nadu, which is endemic to this disease. Okay, in South India, usually in the state of Tamil Nadu. Important is definitely here the patient will have this mulberry like nasal mass. Along with that, this nasal mass which is there, it can bleed at times. So therefore the patient can also have epistaxis. The patient can also develop epistaxis as well. Okay? So there will be Rhinosporidium seaberi, which is the causative agent that you need to remember. Important is, if I talk about the treatment, definitely. Okay, usually the cause is, as I've told you, it is Rhinosporidium seaberi. Very good. It is an aquatic protozoa. So definitely, usually if we take bath in the same pond, which is also used by animals, definitely what can happen? This organism can come in contact with various parts of our body. And which are the common parts which are affected? Most common site is definitely the nasal mucosa, and that is the reason why it is called as rhinosporidiosis. But other parts can be the conjunctiva of the eyes, it can be the oral mucosa or the buccal mucosa. Well, okay, or it can be the anal mucosa as well. Whichever part comes in contact with the dirty water, that can lead to this. Okay, but most common site being the nose. Treatment will be what? Treatment is excision of the mass. Definitely, we need to excise the mass. Okay, treatment is excision of the mass with cauterization of the base. Can anybody tell me what is the drug to prevent recurrence? Because recurrence is very common in this condition. Very good. So, very good. Excision of the mass with cauterization has to be done in this condition. Very good. Whereas the drug of choice to prevent recurrence. Very good. So, please remember, it is not the drug of choice for the disease itself. Okay, it is not the drug of choice for the disease per se. It is the drug of choice to prevent recurrence, and that is what is called as dapsone. The treatment of choice for the disease is always and always excision of the mass followed by cauterization. Okay, so that's the important thing. Very good, all of you. Chalo. Now talking about the next condition, very commonly asked in your exam, and that is what is Csf Rhinuria. What did I tell you yesterday about rhinuria? Rhinuria is nothing but leakage from the nose. And what is leaking this time from the nose? It is the CSF. That is your cerebrospinal fluid, which is normally present where? It is usually normally present in between the meninges, in the subarachnoid space, right? But that is leaking out from the brain or from the cranial cavity. It is leaking out via the nose. Why? Because now we know this is the nasal cavity, this is the cranial cavity. Between the nasal and the cranial cavity, we have a partition. And this partition which is there is known as the cribriform plate. But if in cases the cribriform plate is fractured, what will happen now? Therefore, the CSF will start leaking out from the nose. So usually the most common cause for CSF rhinuria, is definitely trauma. Okay, that can be two types of trauma. Trauma due to some fracture like a road traffic accident vagara, or it can also be a iatrogenic trauma. And what did I tell you about iatrogenic? Iatrogenic, that means you were performing a surgery, and during that surgery definitely the cribriform plate was injured. Okay, or definitely the other causes can be infection, or it can be a malignancy which is causing damage or erosion of the cribriform plate. So definitely the most common site of fracture or CSF rhinuria will definitely be the cribriform plate of the ethmoid bone, which is normally a partition between the cranial and the nasal cavity, that you need to remember. Okay, So very good. Now, if a patient is coming to you after trauma, usually, or after any condition, and there is a watery discharge from the nose, so it is very easy to make it out. Okay, if there is only a watery discharge from the nose, if there is a watery discharge, water-like discharge, because we know CSF is just like water. Okay, then definitely how you will confirm that it is CSF rhinuria in the patient? First of all, you will ask the patient to sniff, pull the or sniff the fluid back. If the patient is unable to sniff back, that means it is the case of CSF rhinuria. Because if it was mucus, patient will be able to sniff it back. Okay, so definitely if it is CSF, sniffing back is not possible. Okay, so sniffing back is not possible at all. Sniffing back is not possible. Next, if you take a handkerchief, okay, on the handkerchief definitely you will take this fluid, and if you keep that handkerchief for some time, what will happen after this handkerchief test you perform? Usually on that handkerchief you will see that the fluid that you have taken now, it is not turn hard. If it is turning hard, if the handkerchief is turning stiff, that means it is the mucus. But if it is still soft, that means it is a watery fluid like a CSF. Okay, so that's the important. If it is sticky, then it is mucus, but if it is non-sticky, then it is CSF. Okay, that is the handkerchief test. And next one definitely important is if a patient comes to you with bloody discharge, if there is a bloody nasal discharge, now it will be very difficult to differentiate whether it is blood or it is a blood mixed CSF. For that reason, definitely you will take the sample on a blotting paper or a filter paper. If you will take the sample on a blotting or a filter paper, you will be able to see that the blood and the CSF will separate out. Okay, and they will form these various concentric rings, and this is classically known as the target sign. This is called as the target sign, and you can see the CSF which is there now, it forms a halo as well. Okay, it forms a halo around the blood as well. That is called as the halo sign. So definitely on a filter or a blotting paper, you will be able to see the target or the halo sign. Important is target or halo sign will not be seen in a case of only CSF rhinuria. It is usually seen in cases of bloody CSF rhinuria, when there is blood along with CSF coming out from the nose. In only that condition you will be able to elicit or able to see these two important signs. Very good. So important is, if I ask you what is the best radiological investigation, what is your answer? If they ask you what is the best radiological investigation, or if they ask you what is the best investigation to find the site of leak, what is the best investigation to find the site of leak? Answer this question once. Whereas yes, overall best investigation, you have already answered it. Overall best investigation, if they only mention, or the gold standard investigation they only mention, definitely the gold standard or the best investigation is collect the sample and send it to the biochemistry lab and ask them to look for a protein, and that is what is called as beta-2 transferrin. So if beta-2 transferrin is present in the sample, definitely confirmation hai कि this is only CSF and nothing else. Okay, so that's the important thing. Beta-2 transferrin estimation in the sample is the best or the gold standard test overall. It will confirm 100% that this is CSF only. That has been asked earlier. Okay, very good. The best radiological investigation or the investigation done to find the site of leak is nothing else but HRCT skull base. Very good. So it is HRCT, high resolution CT scan of the skull base. Very good. What is the treatment? Is it surgical or conservative? Just let me know that. What is the treatment? Is the treatment conservative or surgical? Is the treatment surgical or conservative? Let me know that once. Let me know that once now. Is the treatment surgical or is it conservative? CT cysternography, yes, it is the overall best one, but it is not commonly done. Please remember. But yes, if I talk about if CT cysternography is there in option, then definitely that is a more better option. But if CT cysternography is not there, then you need to mark it as HRCT skull based. Okay, that's the important. CT cysternography is a very good technique as well. So it is also a HRCT scan itself, but over there you will be able to see the leak as well. Very good, very good. It is a conservative management which is the treatment of choice. So conservative management is definitely done. Please remember, conservative management is definitely done. You will ask the patient for bed rest. Why? So that the intracranial pressure decreases. Or if to decrease the intracranial pressure, you can also use drugs like mannitol or glycerol as well. Yes, because the main aim is to decrease the intracranial pressure so that the leak of CSF will stop. Along with that, you will also give antibiotics to the patient so that there will be no meningitis. Otherwise, now you can see the cribriform plate have been fractured. The organisms can easily enter into the cranial cavity and it can lead to meningitis. That's the reason why, to prevent meningitis, we will give antibiotics. We will try this conservative management for a span of 7 to 10 or maximum 7 to 14 days. Even after 7 to 14 days, if the patient does not improve, then we will go for a surgical repair. So, done with this. Next, the last topic from nose is definitely this one. So here, if I talk about the blood supply of the nose, guys, I hope all of you are quite aware that above the middle turbinate, 20% of the blood supply, okay, above the middle turbinate, 20% of the blood supply is given by an artery that is called as ICA, internal carotid artery. That is given by an artery that is known as ICA or internal carotid artery. And two branches of internal carotid artery gives blood supply above the middle turbinate. One is called as the anterior, second is called as the posterior ethmoidal arteries. Okay, so there are two arteries, anterior and posterior ethmoidal arteries, which will give blood supply. Whereas 80% of the blood supply, that means below the middle turbinate. Okay, 80% of blood supply below the middle turbinate, definitely the blood supply is by the external carotid artery. So now if they ask you which is the major artery supplying the nose, now you know the answer. The major artery supplying the nose is the external carotid artery, because it is responsible for 80% of its blood supply. There will be two branches of your external carotid artery which can give blood supply to the nose. One is called as the facial artery. Okay, one is called as the facial artery, and its branch, that is the superior labial artery, will give the blood supply. Its branch known as the superior labial artery, okay, which will also supply the upper lip and also supply some part of the nose. Next is what is your maxillary artery. Now maxillary artery is the terminal branch. I hope all of you are quite aware. So maxillary artery is one of the two terminal branches of ECA, and maxillary artery will give two vessels. One is what is called as the sphenopalatine artery. And the next one is called as the greater palatine artery. Now please tell me which is considered as the artery of epistaxis. That means which artery will have highest chances of nosebleed, or which will have highest chances of nosebleed. Please let me know that. Jaldi se. Which will have highest chances of nosebleed out of all of these blood supply, anterior ethmoidal, posterior ethmoidal, sphenopalatine, greater palatine and superior labial, which will have the highest chances of bleeding from nose or epistaxis? Let me know that once. Let me know that. Fat se ekdam. जल्दी से आंसर करो. Which artery is known as artery of epistaxis? So important is, please remember, it is the sphenopalatine artery. Okay, so please remember, it is the sphenopalatine artery which is the most common one to bleed, and that's the reason why it is also known as artery of epistaxis. Yes, it is also known as the artery of epistaxis. That you need to remember. That's the important thing. Okay, so it is not the greater palatine, it is the sphenopalatine artery which most commonly bleeds. Okay, now these arteries, they usually form a plexus. Okay, these arteries which are there now, they form a network or a plexus usually in the anteroinferior part of the nasal septum. This area where these arteries form a network or a plexus in the anteroinferior part of nasal septum, this area is called as the Little's area, and therefore Little's area is the most common site. Little's area is the most common site for epistaxis as well. Okay, Little's area is also the most common site for epistaxis. Please remember that. Okay, because it contains an arterial plexus. Okay, and therefore this arterial plexus which is there, it is known as Kieselbach's plexus. It is known as the Kieselbach's plexus. And the classical question is, all of the following arteries are a part of the Kieselbach's plexus except? That is a Sarkari question of your exam. So we need to remember, first one is the anterior ethmoidal artery, which is a part. Second is the superior labial artery. Third is the greater palatine artery, and fourth is your artery of epistaxis known as sphenopalatine artery. Which artery which does not takes part in Kieselbach plexus formation is the posterior ethmoidal artery. So please remember this question. Posterior ethmoidal artery is not a part of the Kieselbach's plexus. That's the important thing. Okay? And if there is epistaxis from this anteroinferior part of nasal septum, that is called as anterior epistaxis, most common site being the Little's area, and it usually occurs from the Kieselbach's plexus as well. And it is more commonly seen in children, and the most common cause for it is what? Most common cause for it is nose picking or nail trauma. The children keep on picking their nose now, so that is the most common cause. A person, and please let me know, as I've told you, Most commonly it is seen in children, and in children the most common cause is nail trauma. Okay, that usually causes anterior epistaxis in the children. Important is, please tell me one thing, that in elderly patient, what is the most common cause and which plexus will bleed? In elderly patient, what will be the most common cause and which plexus will bleed? Please let me know that. Which plexus bleeds in elderly patient? Next, if I talk about this, a person was suffering from epistaxis. On pinching the nostrils, okay, the bleed did not stop. On examination, bleeding site wasn't identified. Next line of management is, okay? Now for epistaxis, please remember, there can be multiple causes of epistaxis. One of them I've told you, nail trauma. For elderly, you are telling me. Other causes can be bleeding disorders in a patient like hemophilia or von Willebrand disease, or deficiency of clotting factors, usually in a case of cirrhosis as well, or in cases of nephrotic syndrome also. Okay, so multiple other condition, or thrombocytopenia, it can be ITP or dengue usually in a patient. All of these conditions can lead to this. Now, in cases of epistaxis, we need to go with the flowchart manner, because as you can see that they have given that the patient was tried pinching of nostrils, but the bleed did not stop and the bleeding site wasn't identified. So how to manage this patient? So usually you need to remember this flowchart line to line. Please remember. First technique, if a patient comes to you with epistaxis, is definitely pinch the nostrils. This is called as the Hippocratic method. Pinch the nostrils for a span of 5 to 7 minutes and ask the patient to sit bending forwards. Never ask the patient to lie down. Okay, never ask the patient to lie down. Sone ke liye mat bolo. Otherwise what will happen? The blood will go inside his throat and the patient will have high risk of aspiration of blood. That is the reason why never ask the patient of epistaxis to lie down. Ask the patient to sit bending forwards. Pinch the nostrils for a span of 5 to 7 minutes. If that fails, then definitely go for a chemical or an electrical cauterization. Go for a chemical or an electrical cauterization. Okay? Important is, if you need to cauterize either with the help of some chemical or either with the help of some electricity. We have discussed cauterization usually in surgery, okay, properly. Then what we need to do, we need to definitely identify the bleeding site. Now, you cannot just pour the solution directly into his nasal cavity, or you cannot just cauterize whole of his nasal cavity. So for cauterization, one important reason or one important condition is what? That definitely we need to know the bleeding site. Okay, then only we can perform a chemical cauterization. Okay, so usually for chemical cauterization, we can either use a silver nitrate solution or we can use a phenol solution. Okay, so either silver nitrate or phenol solution, we will dip the cotton into it and press it against the bleeding site. That is usually done. Okay, important is, as I've told you, bleeding site should be identified for chemical cauterization. Okay, so keep that in mind. Next, if that fails, definitely we are going for packing. Okay, so we will definitely go for a packing. If you are sure that it is an anterior epistaxis, only go for anterior nasal packing. If you are sure it is only posterior epistaxis, go for only a posterior nasal packing. But if you are not sure whether it is an anterior or a posterior epistaxis, you are not able to identify the bleeding site, then go for both. This one that you can see over here, you can see this is both. This is the anterior nasal packing which is done usually with a roller or a tape gauge, and this is the catheter which is inserted at the posterior part of the nasal cavity for any posterior epistaxis. Okay, so this is what is the anterior nasal packing and this is the posterior nasal packing. Okay, so this is a Jugadu posterior nasal packing. Why? Because here we have used a Foley's catheter. Please, Foley's catheter is a urinary catheter. बिना यूज किया हुआ यूज करना, ठीक है. Otherwise the one which was there in other patient you have removed and inserted over here. No. Okay, use a newer one definitely, or definitely you can use this catheter which is a specific posterior nasal pack or a posterior nasal catheter. That can also be used. Okay, so that has to be done definitely. So packing has to be done. If packing fails, then what we need to do? Then we need to go for a ligation. And the first artery that should be ligated. We know the most common artery which bleeds is sphenopalatine. So go for endoscopic sphenopalatine artery ligation. If endoscopic sphenopalatine artery ligation also fails, then उसकी माँ को पकड़ो. और इसकी माँ कौन है? Like catch the mother artery. And what is the mother artery for SPAL? It is definitely the maxillary artery. So go for maxillary artery ligation. If maxillary artery ligation also does not help, still the patient is bleeding, then इसकी माँ को पकड़ो. इसकी माँ कौन है? Definitely it is ECA. Okay, if even after maxillary artery ligation the bleed did not stop, definitely go for a ECA ligation. And even after ECA ligation the bleed did not stop. So let me know now, are you going to ligate the ICA of this patient? Okay, please let me know. Okay, after ECA ligation fails, then what you are going to do? Okay, what you are going to do? Let me know that once. Important is definitely Okay, important is in elderly patient, what is the cause? And in elderly patient, the cause is uncontrolled hypertension. In elderly patient, the cause is uncontrolled hypertension. And very good. In elderly patient, more likely there is a posterior epistaxis and there is bleeding from a plexus known as the Woodruff's plexus. Woodruff's is not an arterial, it is a venous plexus. Woodruff's is not an arterial, it is a venous plexus. Okay, so that you need to remember. Okay. So very good. It is not the ICA ligation. जैसी तुमने ICA ligate की patient का राम नाम सत्य है. Okay, so that should not be done. Please remember. So if ECA ligation fails, then definitely go for the ethmoidal artery ligation. Okay, don't ligate the ICA because it also supplies the brain. Okay, so go for a ethmoidal artery ligation in the patient. Okay, anterior and posterior both ethmoidal artery should be ligated. Okay, so that has to be done. So now what is the answer to this question? The question that I've asked. Please answer now. What is the answer to my question? The question that I have asked. A person was suffering from epistaxis on pinching nostrils. The bleed did not stop on examination. Bleeding site wasn't identified. Bleeding site wasn't identified. Next line of management. They have tried pinching of nostrils. Please let me know. Please let me know now. जल्दी से बता दो. So please remember, important is here as the bleeding site is not identified. After pinching nostrils, then definitely we should have gone for chemical or electrical cauterization. But as I've told you, for chemical and electrical cauterization, definitely it is not possible now. Okay, it is not possible because we have because bleeding site is not identified. If you are not able to see the bleeding site, how you are going to perform a chemical or electrical cauterization? That is the reason why here the best answer would be packing. Very good, Shubham. Here the answer would be packing, anterior as well as posterior nasal packing. That should be answer. This was a previous year question. That was all about your nose and paranasal sinuses. Let's start with ear now. Let's start with ear. If I talk about ear, that's the most major part. That is the most major part, definitely. Okay, even silver nitrate you cannot directly pour into his nasal cavity. Please remember. Okay, therefore you should have a identified bleeding site. Then only you can use silver nitrate as well. That's important. Chalo, that is important. Now talking about ear. As I've told you, this is the major part of your ENT. A lot of questions usually are covered in the first three parts. But yeah, majority of the questions can come from ear at times. And that's the reason why you need to remember it. A lot of people are still confused ki ear bahut difficult hai. Ear is not difficult. Let's try to make it simple. Let's try to remember whatever is required. Okay? So that we'll try to do in this session. Important is, please remember, this is which bone? Definitely we all of us are quite aware. This is the temporal bone. It is a skull bone. And in this temporal bone, you are able to see there are various parts. This is the squamous part of the temporal bone. This is the petrous part as well as the mastoid part. So this is the petrous and this is the mastoid part of the temporal bone. And the part which takes part in ear formation, that is called as the tympanic part. Okay, because middle ear is also known as tympanum. So the tympanic part of temporal bone takes part in formation of ear. That's the important thing. So usually ear is actually present inside the temporal bone. Okay? If I talk about ear, ear is actually a journey which starts from the external auditory canal and ends on the internal auditory canal. Okay? So ear is a journey starting from EAC and ending on IAC, and it is going via the temporal bone. Now if I divide the ear into three parts, we know that the ear can be divided into three parts. One is called as the external ear. Okay? The one which is visible. The next is called as the middle ear. And the third one is what is called as the inner ear or the internal ear. Okay? If I talk about the external ear, definitely in external ear we have parts like, first is this part which is visible. It is known as pinna or the auricle. It is known as the pinna, also known as the auricle. Okay? Next is definitely the external auditory canal. As you can see, the pinna continues into the canal. That is called as external auditory canal, also known as external acoustic meatus. And the third part, which is a part of external ear also and the middle ear also, it is nothing but your eardrum, also known as tympanic membrane, also known as myring. Okay? Next is the middle ear. In middle ear, as I've told you, middle ear is a closed cavity. It is just like a closed cabin, and usually it has three ear ossicles. Why? So what are ear ossicles? First of all, these are small bones. Okay, so small bones are called as ossicles, and there are 3 ear ossicles which are present inside the middle ear. They are connected to each other. Why? Because they will help in conduction of the sound. The vibrations will vibrate these ear ossicles, and these vibrations will be carried further with the help of these ear ossicles. So they help in conduction of the sound. That is 3 ear ossicles in the same size. Malleus is the largest. It is the first one. Then medium is the incus, and the smallest one is the stapes. Important is, stapes is the smallest bone of the body as well. Stapes is the smallest bone of the body as well. Apart from this, apart from these 3 ear ossicles, we also have 2 muscles in the ear. We have 2 muscles connected to 2 of the ear ossicles. One muscle which is connected to the malleus, is called as tensor tympani muscle. By the name itself, it is evident. Tensor tympani. That means it is giving tension to the tympanic membrane. So it is stretching the tympanic membrane. So as I've told you, vibrations will be proper if there is a stretched out membrane, just for that reason. So it is tensor tympani which is connected to the malleus. And second is the stapedius. By the name it is evident that stapedius muscle will be connected to the stapes bone. It will be connected to the stapes bone. Next is the inner ear. In inner ear we have 3 parts. The one which is responsible for hearing, the sensory organ of hearing, it is known as cochlea. The next one which is there. Now cochlea is responsible for hearing, but ear also has another function, and what is that? To maintain balance of the body. So that balance of the body is usually maintained by 2 things. One is called as the utricle and saccule. These are present inside a bony covering known as vestibule. So vestibule is nothing but a bony covering which contains this utricle and saccule. So second part you can also call it as the vestibule. And the third part which is there is the semicircular canals. Third part is the semicircular canals. Okay? So utricle, saccule and the semicircular canals, together they are responsible for maintaining balance of your body. Now if I talk about embryology, okay, let's start with embryology. First of all talking about pinna. Now important is, this is what is the pinna looks like. So this conical elevation which is there on the medial side, na, ye jo medial side pe jo conical elevation dikh raha hai, that is what is called as the tragus. This is what is known as the tragus. The opposite to it, this conical elevation is known as antitragus. Then pinna has 2 curvatures na. Ye bahar wala jo curvature dikh raha hai, this outer curvature is known as the helix. Whereas the inner curvature which is there, this inner curvature is called as antihelix. The inner curvature is known as antihelix. And this area which is there, you can see this part which is there. Rest of the pinna you can feel it. It is firm, okay, because it is made up of yellow elastic cartilage. But this area does not contain any cartilage. Therefore, it is very soft. It contains only fat. And what is this area? This area is known as the lobule. Now, important thing you need to remember is, please remember the tragus is formed from the first pharyngeal arc, whereas rest of the pinna is formed from the second pharyngeal arc. Okay, so the tragus is formed from first pharyngeal arc. Okay, so if they ask you about pinna, so please remember the tragus is formed from the first pharyngeal arc, whereas the rest of the pinna, okay, so rest of the pinna which is there, it is formed from the second pharyngeal arc. Definitely. Next is EAC. What is EAC? EAC is nothing but external auditory canal. Okay, EAC is nothing but external auditory canal, also known as external acoustic meatus. It is usually developed from the first ectodermal cleft. Okay, that's important. Next is tympanic membrane. Please let me know tympanic membrane develops from which germ layer. Now please remember, this is the endodermal pouch. Now we know this is the first endodermal pouch. Okay, this is the first ectodermal cleft. Okay, and here we have this mesodermal arc. This is the first mesodermal arc or the first pharyngeal arc. Okay. Now usually, as you can see, over here, definitely this first ectodermal cleft, I have told you, it will develop into the external auditory canal or the ESC. Whereas the first endodermal pouch, it will develop into what? The first endodermal pouch. Please remember, it will develop into the middle ear. The first endodermal pouch will develop into the middle ear. So you can see, so the external auditory canal and the middle ear are meeting at this point. And what is this point where the external auditory canal and the middle ear meet? This is the tympanic membrane. So you can see that the tympanic membrane will be formed in between. Okay, the tympanic membrane will be formed in between itself. Therefore, it has contributions from all the 3 germ layers. So tympanic membrane is formed from all 3 germ layers. That is ectoderm, mesoderm and endoderm. So please remember, if they ask you which is the structure in the ear which is formed of all the 3 germ layers, now you know the answer. that is tympanic membrane or the eardrum, which is formed of all the three germ layers. It will also have contribution from the endoderm, mesoderm as well as the ectoderm. Okay. Next is the middle ear, the antrum. Antrum is what? We will discuss it. The mastoid bone is over here now. So the mastoid bone also have some small air cells. Okay, small sinuses. And the largest mastoid air cell which is there now, that is what is known as mastoid antrum. Okay. So therefore the middle ear, the mastoid antrum and the eustachian tube. Because we know that middle ear is connected to the nasopharynx with the help of this eustachian tube. So the middle ear, the antrum and the eustachian tube, all of these are formed from the first endodermal pouch. They are formed of the first endodermal pouch definitely. Okay, as I've told you already. Next is definitely ear ossicles. So please remember, if I talk about ear ossicles, you need to remember important hai. Malleus and incus which are there. The malleus and incus, they are developed from the first pharyngeal arc. Malleus and incus are developed from the first pharyngeal arc, whereas the stapes is developed from the second pharyngeal arc. Stapes develops from the second pharyngeal arc. That's important. Next, if I talk about the middle ear muscles. Now this you will tell me. Okay, this you will be telling me. Now please remember, tell me that the tensor tympani muscle. Tensor tympani muscle will develop from which arc? And second, the stapedius muscle will develop from which arc? Tensor tympani develops from which arc and the stapedius develops from which arc? That you need to tell me. Next is the inner ear and the cochlea. So inner ear also contains the cochlea. So all of the inner ear and the cochlea definitely, they are formed from neuroectoderm. Yes, it is not formed of the pharyngeal arcs. It is formed of neuroectoderm usually. ठीक है, neuroectoderm से क्या बनता है? There is a aortic pit, then there is aortic vesicle, or there is a aortic placode. So in one of the examinations earlier, there was aortic placode in the option. So don't get confused. Neuroectoderm का एक हिस्सा होता है, that is called as aortic placode, which forms the inner ear or mainly the cochlea. That is important. Okay, that is important to be remembered. Please let me know. These are important one-liners. You can just remember them. So please remember the tensor tympani muscle, as malleus is developed from the first arc, therefore the muscle which is attached to it, tensor tympani, it will also be developed from the first arc. Whereas as stapes is developed from second arc, the muscle attached to it, the stapedius, it will also be developed from the second pharyngeal arc or the second branchial arc as well. Okay, so that's the important thing you need to remember. These are the important things about embryology. Please remember this. Okay, now talking about some congenital anomalies. Now let's talk about some congenital anomalies. So this first one that you can see over here. Now as I've told you that the tragus of the pinna develops from the first pharyngeal arc, whereas the rest of the pinna develops from the second pharyngeal arc. This is the site where the first and the second pharyngeal arc will meet. Okay, this is the site where the first and second pharyngeal arc will meet, and you will see over here that at this point there is no cartilage present. Okay, this area which is there, it is devoid of cartilage. This is what is called as incisura terminalis. So what is incisura terminalis? Incisura terminalis is nothing but the area where the first and the second pharyngeal arc will fuse together. Okay, but in case if these do not fuse with each other, if the first and the second pharyngeal arc does not fuse, okay, no fusion occurs of the first and the second pharyngeal arc, then it leads to formation of this hole you can see, and this is what is called as a preauricular sinus. It leads to formation of this condition that is called as a preauricular sinus. Okay, so yaad rakhna, at incisura terminalis, if the first and the second pharyngeal arc does not fuse with each other, it leads to formation of a preauricular sinus. Nothing has to be done because here the patient will not have any kind of complaint usually. It is so small sinus, there will be no infection, there will not be any collection of fluid also in it. Okay, it is a very small sinus. Next is this. This is not a congenital anomaly, but rather it is a normal anatomical variation. किसी इंसान में दिखता है. Some people we might see this. This is a conical elevation on the helix you can see. Okay, there's a conical elevation on the helix, and this is what is called as Darwin's tubercle. Is there any treatment? No treatment is to be given. Why? Because this is just a normal anatomical variation. There is no congenital anomaly in this patient. This is a normal anatomical variation known as Darwin's tubercle. Okay, so that is important. Next is this condition. Yes, this is a congenital anomaly. Which movie it reminds you of? Definitely PK, right? Amir Khan. So definitely this you can see in his ear, the outer curvature is present. मतलब helix is definitely present, but जो inner curvature है, जो अंदर वाला curvature है, वो क्या दिख रहा है क्या? नहीं दिख रहा. So definitely the inner curvature is absent. So that means the anti-helix is absent. This is a condition where the anti-helix will be absent. And if anti-helix is absent, definitely there will be a deformity of ear, and that is what is called as bat ear. This is what is classically known as the bat ear. Now please tell me, for bat ear definitely, as it does not look good, therefore we will go for a plastic reconstruction. But tell me what should be the time of plastic reconstruction. What should be the time of plastic reconstruction? One important thing about embryology that I'll tell you, so it will be related to it. So I'm telling you, important is there are two structures, that is the pinna as well as cochlea. Pinna and cochlea in the ear, which will complete its development. Okay, they will complete the development by 20 weeks of intrauterine life. Yes, complete development by 20 weeks of intrauterine life will be there. Okay, there will be a complete development of these two structures, pinna and cochlea, by 20 weeks of intrauterine life. Okay, so these are the two important structures you need to remember. Plastic reconstruction का time क्या होना चाहिए then? Please let me know. What should be the time of plastic reconstruction? Very good. It should be performed usually after 6 or 7 years of age. The reason is, sir, you will say, sir, development तो complete हो चुका है fetus में. Okay, the development was complete at 20 weeks of intrauterine life only, na? So why we need to wait for 6 or 7 years? So the reason is, please remember, definitely the patient will have growth of the pinna, na? Definitely it will not develop further, but there will be growth in size, na? So the pinna grows in size till 6 or 7 years of age. That is the reason why usually we need to wait up till 6 or 7 years of age, and then we'll go for autoplasty. That is what is plastic reconstruction of the pinna. This condition, as you can see, here you can see a very small and underdeveloped pinna. This small and underdeveloped pinna is what is called as microtia. A small and underdeveloped pinna is known as microtia, whereas this one, you can see there is a complete absence of pinna over here. And if the pinna is completely absent, that is called as anosia. These are two important anomalies. Remember them, because I'll be asking you questions regarding them in the hearing aid wala part. Okay, chalo. Moving further, talking about this one now. These are the ear ossicles. Okay, these are the ear ossicles. The largest ear ossicle, as all of us are quite aware, it is the malleus. And these ear ossicles are present where? These ear ossicles are present in the middle ear cavity or the tympanic cavity, definitely. Okay. And here you can see the largest ear ossicle which is there, definitely. It is known as malleus. This is the head of the malleus, the neck of the malleus. This is the lateral process of the malleus. This is the long process of the malleus, or the handle of the malleus. Okay, handle of the malleus. And this is what is the tip of the malleus, known as umbo. Okay. Whereas this is the body of the incus. This is the incus bone, which have come as an image in the NEET PG 2022 examination. So it can come in your examination also. Okay, so this first one, that is your body of the incus. This is the lateral short process of the incus, long process of the incus, and this curved one is the lenticular process of the incus. Okay, whereas the last one which is there now, this one is the stapes. Okay, the smallest bone or the smallest ear ossicle. This is the head of the stapes, neck of the stapes, suprastructure of the stapes, and this is the foot plate of the stapes. And we know this foot plate of the stapes is attached to the oval window. The foot plate of the stapes is attached to the oval window of the inner ear. Okay, that is important to be remembered. Next, this one is what is your normal tympanic membrane. And as I've told you, tympanic membrane is also known as eardrum in layman language, or it can also be called as myring in Latin. It's also known as myring in Latin. Important is this tympanic membrane which is there. It is usually oval, okay, and it is pearly white or pearly gray in color, okay. And apart from this, it is 90 millimeters square. The surface area of tympanic membrane is 90 millimeters square. The diameter is around 9 to 10 mm. Important is this tympanic membrane, when we examine it with the help of an otoscope. Okay, if you examine the tympanic membrane with the help of an otoscope, usually you will be able to see 4 important landmarks. Why we are able to see the landmarks? Why we need to see the landmarks? Because if the landmarks are not present, then we can say definitely there is some problem in the ear of this patient. Okay, so that has to be remembered. So there are 4 landmarks which is there. These 4 landmarks, the first one that you can see is the lateral process of the malleus. The first landmark which is there is the lateral process of the malleus. Second landmark, as you can see, it is the handle of the malleus. Second is the handle of the malleus. Third is this. What is this? This is the light reflex. Okay, the otoscope has a light source and that reflects on the tympanic membrane. So this is the light reflex, also known as cone of light. Also known as cone of light. I hope all of you are quite aware. In right ear, it will be present at 5 o'clock position, and in left ear, it will be present at 7 o'clock position. Okay. And the fourth landmark which is there is this, the tip of the handle, that is known as umbo. The tip of the handle known as umbo. Now, all of you will be answering me, out of these 4 landmarks on the tympanic membrane, which is the most reliable landmark? Which is the most reliable landmark? That is the question to you. Which is the most reliable landmark of tympanic membrane? If I talk about the tympanic membrane, as I've told you, that it will have 2 parts. The upper part which is there, it is known as pars flaccida. Okay, why? Because it is loose. Therefore, it is known as flaccida. It is known as pars flaccida. It is also called as the Sharpnell's membrane. It is also known as the Sharpnell's membrane. Whereas the lower part which is there, it is called as pars tensa. The lower part is known as pars tensa because it is tensed out, it is stretched out properly. Okay? So that's the important thing you need to remember. Okay, so pars flaccida usually only has two layers. There is an inner mucosal layer and outer skin layer. But pars tensa has three layers. It has inner mucosal layer, outer skin layer, and middle fibrous layer as well. Okay? Please let me know which is the most reliable landmark out of all these. Which is the most reliable landmark out of all these four. So please remember, the most reliable landmark of the tympanic membrane is the umbo. The most reliable landmark out of all these four is the umbo. That you need to remember. Okay? No issues till anybody? That is important to be remembered. If I talk about the main nerve supply of the pinna, answer this question now. Chalo. Main nerve supply of pinna bata do mujhe. Okay, main nerve supply of pinna. Tell me about the main nerve supply of pinna. Till that time, I'll talk about this condition of pinna. And what is this condition of pinna called as? So a patient, usually a young guy, had a fist fight with his friends, and now as he had a fist fight, there was trauma to his ear. Or usually a boxer after a fight comes to you with this condition. And what is this? You can see there is blood collection over here in the pinna. Okay, between the cartilage and its covering, known as perichondrium. So in this, between the cartilage and its perichondrium, there's collection of blood. That is called as a hematoma. So definitely the patient will have hematoma over here. This is a condition known as pinna hematoma. The most common cause of pinna hematoma, we know it is trauma definitely. And what should be done for treatment? Just like for septal hematoma we were doing, here also we will go for aspiration. Here also we can go for an aspiration or an incision and drainage. Followed by that, we need to apply a pressure bandage. In cases of septal hematoma, we were applying nasal packing now. Just like that, here we need to apply a pressure bandage definitely. Otherwise, there can be recollection of the blood. There can be recollection of hematoma again. Okay. So aspiration or incision and drainage followed by pressure bandage has to be applied. That is the case of pinna hematoma. If the pinna hematoma is not treated, what will happen? Definitely, the patient will develop a post-traumatic ear deformity, which is usually seen in boxers because they constantly get these pinna hematomas. And this pinna hematoma will turn into a deformity called as a cauliflower ear. It is known as a cauliflower ear or a boxer's ear. It is known as the cauliflower ear or the boxer's ear. Okay, so that's important. Yes, all of you are right. The major nerve supply of the pinna, definitely all of you are right. It is a greater auricular nerve. The major nerve supply of the pinna, you need to remember, it is a greater auricular nerve. Okay, so that has to be remembered. It is a branch of the ansa cervicalis. C2, C3 is the root value. Okay, greater auricular nerve. Then if I talk about the EAC, what is EAC? As I've told you, external auditory canal or the external acoustic meatus. Now in this EAC, okay, important is, it is how much in length? This EAC which is there, it is usually 24 mm in length. Okay, it is 24 mm in length. And please remember, the outer 1/3 which is there, the outer 1/3 which is there, that is around 8 mm. It is cartilaginous in nature. It is made up of cartilage. Pinna is also made up of cartilage. So therefore, the part which is in connection with the pinna, the outer 1/3, it is also made up of cartilage. But the inner 2/3 which is there, the inner 2/3 towards the middle ear, the inner 2/3 part, it is actually bony in nature. The inner 2/3 part is bony, and which bone? Definitely we know it is a temporal bone always. Okay? So that's the important thing you need to remember. Now this external auditory canal which is there now, here definitely you will be able to see there are two natural defects in this external auditory canal. And these two natural defects which are there in the external auditory canal are the first one which is present in the cartilaginous part. The first one which is present in the cartilaginous part are called as fissures of Santorini. The first one is known as the fissure of Santorini. You can see these are the two defects in the cartilaginous part. Then one defect which is present, okay, one defect which is present in the bony part. That is what is called as the one defect which is present in the bony part. It is known as foramen of Huschke. Okay, the one defect which is present in the bony part is known as foramen of Huschke. Now, why are these defects so important? Because via the fissure of Santorini or via the foramen of Huschke, you can see the infection if there is some infection in the external ear. Okay, if there is some infection in the external ear, this infection via these openings, it can directly reach to this gland. And what is this gland? This is what is the parotid gland. So infection via this external auditory canal can easily reach the parotid gland. Therefore, the patient can develop parotid gland infection, that is parotitis. Okay. So if they give you a parotitis case after a ear infection, then you need to think, okay, the infection might have spread from these two natural defects in the external auditory canal, known as the fissures of Santorini in the cartilaginous part and the foramen of Hashke in the bony part of the EAC. Okay, chalo. That is important to be remembered. Next, if I talk about the nerve supply of EAC, and this is very important, guys, have been asked multiple number of times. So the first one, the green part that you can see, it is supplied by the auriculotemporal nerve. So please remember, the auriculotemporal nerve usually supplies the roof and the anterior wall. Okay, the auriculotemporal nerve supplies the roof and the anterior wall of the external auditory canal. And this auriculotemporal nerve is a branch of V3. What is V3? V3 is nothing but the third division of the trigeminal nerve. And what is the third division of trigeminal nerve called as? Mandibular nerve. So please remember, auriculotemporal nerve which is there, it is a branch of mandibular nerve and it will supply the roof and anterior wall of EAC. Okay? So that is to be remembered. Next, this purple part that you can see over here. The purple part, as you can see, it will supply the floor and the posterior wall of EAC. Okay? It will supply the floor and the posterior part of or a posterior wall of EAC, and definitely important is it will be innervated by what? It will be supplied by the auricular branch of vagus nerve. It will be supplied by the auricular branch of vagus nerve. Please remember that. Okay, this auricular branch of the 10th cranial nerve or the vagus nerve, it has a specific name. And what is this called as? It is also known as the Arnold's nerve or the Eiderman's nerve. It is also known as the Arnold's nerve or the Eiderman's nerve. That is important to be remembered. Next important is this yellow part. The yellow part which is there, this is innervated by, it is actually the postero-superior part of EAC. It is the postero-superior part of EAC, and that is innervated usually by the sensory division of facial nerve. And the sensory division of facial nerve, it has a characteristic name. It is known as nerve of Würzburg. Okay, the sensory division of facial nerve which supplies the postero-superior part of EAC, it is known as the nerve of Würzburg. Okay, so Arnold's nerve is important, or Eiderman's nerve, which is nothing but the auricular branch of vagus, and second, the nerve of Würzburg is important. It is nothing but the sensory division of facial nerve. Okay? So these are the important things to be remembered about your external auditory canal. Now talking about this condition. Here the patient is coming to me with complaints of hearing loss. There is a mild conductive hearing loss in this patient. Mild conductive hearing loss in this patient. When I perform an otoscopic examination, on otoscopy I'll see that there is a lot of earwax in the patient's ear. There's a lot of earwax. So we know that the external auditory canal is lined by skin. And this skin not only has hair follicles in it, but it also has these ceruminous glands. And what is the function of these ceruminous glands? These ceruminous glands are known to produce earwax. But if this earwax is produced in excess, definitely that can cause blockage in the external auditory canal, and that can lead to a conductive hearing loss in the patient. So if there is a conductive hearing loss, what we need to do? We need to clean the ear. If there is excess of earwax, we need to clean the ear. And that is what is done by the procedure shown in the image called as ear syringing. That is done by a procedure shown in the image known as ear syringing. Okay, so ear syringing means here they are using a metallic syringe. You can also use a plastic syringe, but usually a larger one, 50 cc or a 60 cc syringe should be used. But the water that should be used, please remember, the water that should be used should be a warm water. Okay, it should be warm water, and the direction of ear syringing should be postero-superior. So it should be in this direction, postero-superior. So the water will go behind the earwax and it will pull out the earwax. So the direction should be postero-superior. Why? Because if you don't follow this, definitely that will lead to some complications or some problems in the patient. And what are those? Let's see that. Okay? So you should use warm water and the direction should be postero-superior. If I perform it with cold water, then what will the patient experience? All of these are previous year questions now. All of these are previous year questions. Just attention for 2 minutes. Okay? All of these are previous year questions. Jaldi se bata. If I use cold water instead of warm water, what will the patient experience? So they will classically give you a history that after ear syringing, the patient experiences this complaint. So what is the likely cause? That is how the question is framed. What the patient will experience after syringing if I use cold water. Very good, Karishma. Very good. The patient will experience vertigo. Okay, the patient will experience vertigo, definitely. Okay, if my direction is antero-inferior, my direction is not postero-superior, my direction is antero-inferior. What will happen? If my direction is antero-inferior, I am irritating the floor. And which nerve is supplying the floor? The nerve is known as auricular branch of vagus nerve, or the Arnold's or Eiderman's nerve. Therefore, if I do the ear syringing in the antero-inferior direction, I am irritating. There is irritation of the Arnold's nerve. There is irritation of the Arnold's nerve. And we know Arnold's is nothing but a branch of the vagus itself. Therefore, if the vagus nerve is irritated, what did I tell you yesterday? If one nerve is irritated, it will not only cause pain or problem, at the site of irritation, but it will cause problem everywhere. Wherever it is going, it will cause problem everywhere. That is the reason why definitely if there is irritation of the Arnold's nerve, the whole vagus nerve will be irritated, and the patient will have two conditions. One, as vagus nerve also innervates the throat now with the help of your RLN and SLN. Therefore, the patient will have a cough reflex. The patient will have a cough reflex after syringing. So you need to remember, okay, the direction was anterior-inferior then, and there was irritation of the Arnold's nerve. Or as we know that the vagus nerve which is there, it also gives a parasympathetic nerve supply to the blood vessels. Okay, therefore what will happen? There will be sudden vasodilation. The blood pressure will suddenly drop as soon as the vagus nerve gets irritated. There will be a sudden vasodilatation. Okay, the blood pressure will suddenly drop and the patient will suffer from a syncopal attack. Okay, the patient will fall down. Okay, that is called as a vasovagal syncope. That is what is known as a vasovagal syncope. So if you perform it in anteroinferior direction, irritation of Arnold's nerve, that will cause cough reflex and vasovagal syncope. Okay, just give rest to the patient if this happens after syringing. Okay. Next is the diseases of external auditory canal. The first one that is shown in the image, what you can see on otoscopic examination, I am able to see that there is a pimple or a pus pustule like condition which is present in the external auditory canal. This is a case of localized otitis externa. By the name it is evident, localized. Okay, that means only some part of the external ear is affected. Otitis externa, that is infection of the external ear. So localized otitis externa is also known as furunculosis. Why? Because it is nothing else but a furuncle itself. And what is a furuncle? Furuncle is nothing but infection of a hair follicle. Furuncle is nothing but an infection of hair follicle. And what is the most common cause for a furuncle? Which is the most common organism responsible for a furuncle? Please tell me that. Most common cause for a furuncle is what? Okay, most common cause for a furuncle will be what? Okay, here the patient will definitely have some earache. Okay, usually the patient has earache, that is the complaint. And if they ask you about treatment, definitely as it is an infection, we will go for antibiotics. But along with antibiotics, the important thing that we usually do is the IG packing. What is IG packing? Ecthymemol glycerine packing. We will go for a ecthymemol glycerine packing. This was a previous year question. Ecthymemol glycerine packing has to be done. So the most common cause for a furuncle everywhere. Okay, it is Staph aureus. Very good. Okay, so the most common cause is usually an organism known as Staph aureus. Okay, that has to be remembered. Please remember, anywhere in the body, wherever there is furuncle, the most common cause is Staph aureus. Okay. Next will be, now there was only localized infection. Now, if the infection spreads to the whole of the external ear. If the infection spreads to the whole external ear, then it will be called as diffuse otitis externa. And when the patient will develop a infection of the external ear, when the ear is constantly wet, when the ear is constantly moist, then the risk of infection will definitely increase. Very good. Here, in cases of diffuse otitis externa, the cause will be Pseudomonas. In cases of diffuse otitis externa, the cause will be Pseudomonas definitely. And here definitely the patient will have, the patient will need only antibiotics. The patient will have pain definitely over here. Okay. If I talk about diffuse otitis externa, guys, please remember, as I've told you, moisture is an important risk factor for developing diffuse otitis externa. That is the reason why moisture is usually seen in tropical countries, okay, like Singapore, vagera. Therefore, it is known as tropical ear. It is also known as Singapore ear, or usually swimmer's ear as well. Why? Because swimmers will also have this constant moisture in their ear. Okay, so it is known as tropical ear, Singapore ear, or swimmer's ear. That has to be remembered. That has to be remembered properly. Okay. Next, make a diagnosis. Yes, trigger sign will be positive, right? Make a diagnosis of this question. An elderly diabetic patient comes with complaints of severe earache, and there is also some ear discharge, as you can see in the image as well. And the patient is having features of facial nerve palsy. The patient is also having features of facial nerve palsy. That means it is a severe infection, right? Along with that, there are granulations are seen in the external auditory canal when we are performing an examination. What is the diagnosis? What is the diagnosis? Make a diagnosis of this question, first say. Make a diagnosis of this question. Make a diagnosis of this question, guys. Elderly diabetic patient, that is an immunocompromised patient. Elderly diabetic means, okay, severe earache hai, ear discharge hai, facial nerve palsy, ear discharge hai, तो more likely it can be either a middle or an external ear infection. Along with that, there is facial nerve palsy and granulations also seen inside the external auditory canal. It is not Ramsay Hunt. It is not Ramsay Hunt. In Ramsay Hunt, there will be painful ear vesicles. Very good, Karishma. It is malignant otitis externa. Very good. So it is a case of malignant otitis externa. Please remember, if I talk about malignant otitis externa, okay, that is nothing but a severe external ear infection. Malignant is not because it is a cancer or a malignancy. It is because it is a severe and a life-threatening infection of the external ear. Okay, it is usually seen only in immunocompromised patients, like an elderly diabetic patient, an immunocompromised patient, like HIV positive patient, or usually a COVID-19 patient on a chronic or a long-term steroid therapy. Definitely, all of these patients are at a high risk of developing malignant otitis externa. But the question usually starts. This is a keyword: elderly diabetic. This is a keyword not only for mucormycosis but also for malignant otitis externa. Please remember that. Okay. Now here the most common cause. Definitely severe infections are usually caused by a bacteria known as Pseudomonas. So here the most common cause is Pseudomonas aeruginosa. The most common cause is Pseudomonas aeruginosa for sure. Okay. And as we know, why it is considered life-threatening? Because it also spreads to the skull base and it will lead to infection of the skull base. Infection of the bone is called as osteomyelitis. So the patient will have skull base osteomyelitis, and what exits out from the skull base usually, it is the cranial nerve. That is the reason why the patient will have multiple cranial nerve palsies. The patient will have multiple cranial nerve palsies as well. So if they ask you which is the most common cranial nerve palsy, somebody has answered it already. So the most common cranial nerve palsy, please remember, definitely the facial nerve does not arise from the skull base. It enters into the ear. But as we know that if I talk about which is the closest nerve to the external ear, it is definitely the facial nerve. Na? Therefore, the most common nerve or the earliest nerve to be involved is definitely the 7th cranial nerve or your facial nerve. The most common or the earliest nerve to be involved is definitely the 7th cranial nerve or the facial nerve. Not because it arises from the skull base, but because it is in close relation to the external ear. That is the reason why. Okay. And apart from that, definitely if it spreads to the skull base, there will also be involvement of the 9th, 10th, 11th and 12th cranial nerves. 8th cranial nerve, there will be lesser chances because the 8th cranial nerve which is there now, it is present inside the inner ear only. It does not come outside the inner ear. Therefore, very less chances of 8th nerve involvement. It is 7th most common and others are 9th, 10th, 11th and 12th. Okay? That is important. What is done for treatment? Definitely. So treatment के लिए definitely we need to give antibiotics to the patient. And what is the antibiotic that is given? A broad spectrum antibiotic is needed because not all the antibiotics are effective against Pseudomonas. So we only need specific antibiotics. And here we will give 3rd generation cephalosporins. Drugs like ceftriaxone or ciprofloxacin can also be used. Okay. Either we will use ceftriaxone, a 3rd generation cephalosporin, or we will use a fluoroquinolone like ciprofloxacin. Okay. Ciprofloxacin is the oral drug. But usually this patient needs a long-term antibiotic therapy, usually for 6 to 7 weeks or till the infection resolves. Okay? So that is how you need to remember that. Okay? That is important. Next is this one. As you can see over here, this is what is called as, on otoscopy you can see there is a blackish and whitish appearance in the external auditory canal. And it appears wet also. There is some kind of pus also. This is the characteristic wet newspaper appearance. This is the characteristic wet newspaper appearance. Seen in which condition? Let me know that. This is the characteristic wet newspaper appearance seen in which condition of external ear. Okay. So please remember, yeah, ceftazidime can also be used nowadays. Ceftriaxone is definitely commonly used. Okay. If they ask you commonly, so it is very commonly used because most of the cases we do not have other drugs only. Okay. Government hospitals में monosef मिल जाए, ये बड़ी बात होती है. That's the important thing. Wet newspaper appearance. If I talk about this condition, this is nothing but very good Kartika, very good Nagendra. It is otomycosis. It is nothing but fungal infection of the external ear. Mycosis, याद रखना, जहां जहां mycosis आता है, it means a fungal infection except botryomycosis, which is a staph aureus वाला infection, and mycosis fungoides, which is a cutaneous T cell lymphoma. Except these two conditions, everywhere mycosis means a fungal infection, and otomycosis means a fungal infection of the external ear. And the most common cause for it is definitely Aspergillus niger. Most common cause for it is definitely an organism or a fungus known as Aspergillus niger. Niger का मतलब ही होता है black. That is the reason why there will be a white and a black appearance in the external ear known as the wet newspaper appearance. Second common cause can be Candida albicans and it causes everything white. That is called as the cotton ball appearance as well. Okay? Treatment will be what? Here the main complaint is not earache because as I've told you, please remember, in bacterial infection the main complaint is earache or pain in the ear. But here the main complaint of the patient will be itching. That is how you differentiate. Okay, fungal infections mainly cause itching usually. Treatment, if I talk about, where definitely we need to give antifungal ear drops to the patient. But prior to give antifungal ear drops, we need to clean all this ear. And cleaning the ear is what is called as oral toilet. Cleaning the ear is what is called as oral toilet. Okay, that has to be done. Next are these important conditions. What is seen over here, as you can see some blebs which are formed over the tympanic membrane. These blebs, okay, blebs are nothing but bulle, you can call them. So these blebs are air-filled blebs which are formed, balloons which are formed over the tympanic membrane. They are formed over the tympanic membrane. Please remember that. Okay? These are not bubbles which are present behind the tympanic membrane, because there's an important thing which we will differentiate it from. Okay, we will talk about it later, but please remember, this is the blebs which are formed over the tympanic membrane, and this is what is called as, please remember, this condition is what is called as bullous myringitis. This condition is what is called as bullous myringitis. It is due to an infection only. It is known as bullous myringitis, definitely, or we can call it bullosa, myringitis bullosa. Okay, or you can call it as myringitis bullosa. It is one and the same thing. Okay, it is seen as a complication of infection. After the infection, when the patient will form blebs usually, or these balloons over the tympanic membrane, this condition, spot diagnosis hai bas ye. At least identify the condition, that is what is bullous myringitis or myringitis bullosa. Okay, myringitis is infection of the tympanic membrane that causes this bulla or bleb formation. Next is what? Here you can see there is perforation, definitely, I'll talk about that later. But apart from that, you can see that there is whitish appearance of the tympanic membrane. What did I tell you? Tympanic membrane is pearly gray or pearly white in color, but here it appears completely white. Chalk jaisa dikh raha hai ekdam. Okay, it appears like chalk or calcium. This is what is called as calcification of the tympanic membrane or fibrosis of the tympanic membrane. That is what is called as tympanosclerosis. Okay, just remember the term. If the tympanic membrane appears completely white due to calcification or due to fibrosis, that is called as tympanosclerosis. Again, a spot diagnosis. It can be seen after an infection. When the infection will heal, definitely there will be fibrosis. Okay, so जब infection heal होता है ना, definitely तब जाके fibrosis हो जाएगा tympanic membrane का, और तब वो ऐसा chalky white appearance दिखाएगा. That is tympanosclerosis. ठीक है, I'll use Hindi as well in between, no worries about that. Next, ये condition क्या दिख रही है? Now here you are able to see that the landmarks of the tympanic membrane have been lost. Landmarks दिखाई दे रहे क्या? नहीं दिखाई दे रहे. तुम्हें landmarks ही नहीं दिखाई दे रहे tympanic membrane के. That means there is some problem in the tympanic membrane because the landmarks are not visible. Now definitely what is seen over here, that the tympanic membrane is sucked inside. Okay, so definitely the tympanic membrane which is there ना, उसको क्या हुआ है? वो अंदर खींचा जा चुका है. क्यों? Because there is suction of the tympanic membrane inside. That is also known as retraction of tympanic membrane. That is what is called as retraction of tympanic membrane, guys. Okay, so retraction of tympanic membrane कब होता है? Just let me tell you that important. So please remember, this is the middle ear, this is your eustachian tube, right? What did I tell you? One of the important functions of eustachian tube is to drain all the secretions of middle ear. जितना भी middle ear में secretions बनते हैं, वो nasopharynx में डालना वो eustachian tube का काम होता है. Second function is what? Definitely it is also responsible to maintain the air pressure inside the middle ear. eustachian tube का काम दूसरा ये होता है कि जो middle ear का जो air pressure है ना, उसको maintain करके रखना अच्छे से. But in cases where the eustachian tube gets blocked, अगर eustachian tube block हो जाती है, so what will happen in that condition? Definitely there will be a negative pressure generated inside the middle ear. Okay, एक negative pressure generate हो जाएगा middle ear में, and that will create a vacuum or that will create a suction. उसकी वजह से एक vacuum या suction हो जाता है. Due to that, what will happen? The tympanic membrane will be sucked inside. Okay, it will be pulled inside. That is what is called as retraction of tympanic membrane. Okay, along with that, you are able to see this blackish appearance. That is nothing but the keratin which has been deposited. Okay, so this is what is the keratin which has been deposited in the retracted part of the tympanic membrane. You can see the keratin, the black color material is nothing but the keratin which has deposited. Okay, next is what is this? क्या दिख रहा है? Here definitely a teacher has slapped a student, and after slapping a student on the ear, the patient or the child is having mild conductive hearing loss. The child is having a mild conductive hearing loss, and now the child was brought to the OPD, and on otoscopic examination you are able to see that there is no infection वगैरह, but there is a hole or there is a perforation in the tympanic membrane. So this is a case of non-infective or a traumatic tympanic membrane perforation. It is a case of traumatic tympanic membrane perforation. What is the treatment in this condition? This was a previous year question. बता दो treatment क्या करोगे इस condition में? When traumatic tympanic membrane perforation will occur, there is no infection as such. कोई दिख रहा है कि redness, inflammation कुछ नहीं है. There is no inflammation as such. Please let me know what will be your treatment. What will be your treatment? Yes, it is a case of tympanic membrane rupture or a tympanic membrane perforation. What should be the treatment? Jaldi se. Anybody? So please remember, in this condition, the treatment for tympanic membrane rupture or perforation, if it is non-infective, if it is due to trauma, then the treatment is only reassurance. Why reassurance? Because the tympanic membrane, if it is not infected, it will heal by itself. It will spontaneously heal. अपने आप ठीक हो जाएगा in a span of 3 to 6 months. Okay, it will usually heal by itself in a span of 3 to 6 months. Only if there is infection, then definitely the tympanic membrane could not heal by itself. Otherwise, it can heal by itself. It is self-resolving. Okay, it is a self-resolving condition. Okay, conservative. If reassurance is not an option, then definitely you can mark it as conservative. Or if that is also not an option, as I've told you, you can also mark it as no treatment. Okay, so that was a previous year question that you need to remember. Now talking about the middle ear. If I talk about the middle ear, as I've already told you, that middle ear is a closed cavity. It is just like a closed room or a closed cabin, which usually has 6 walls. It has a roof, it has a floor, it has an anterior wall, a posterior wall, a medial wall, and a lateral wall. Okay, so that is what is the middle ear. Now this middle ear is also known as tympanum, and the middle ear cavity will also be called as a tympanic cavity. This middle ear, it is usually formed within the temporal bone. So middle ear is usually present inside the temporal bone. That's the important thing. Now important is, in the middle ear, as I've told you, there is ear ossicles. Okay, and what is the function of the ear ossicle? Conduction of the sound. But we have seen that the ear ossicles which were there, the malleus, the incus, and the stapes, they were in decreasing order of size. They were in decreasing order of size. Why? Because the main function of the middle ear is what? The main function of middle ear is not only to conduct the sound, but rather it is impedance matching. What is impedance matching? For those who want to understand, you can just remember, I'm just explaining it to you once. I'm explaining it in Hindi and English both. Okay, just remember once. Impedance matching is what is present inside the inner ear. In inner ear, we have fluids called as the endolymph and perilymph. Therefore, when the sound or whenever the vibrations will reach inside the inner ear, what will happen? These vibrations or the sound will be diminished, because whenever the sound or the vibration need to travel via liquid medium or a fluid medium, it will have more resistance. That is the reason why definitely there will be diminution of the sound. To overcome that, okay, we know that the sound has to be diminished in the inner ear. To overcome that, definitely what we are trying to do in the middle ear only, we are trying to amplify the sound. We are trying to increase the intensity of the sound. That is called as amplification of sound, and that is what is impedance matching. That is usually done by the decreasing size of the ear ossicles. Along with that, the difference in the surface area of the tympanic membrane and surface area of the oval window. Together, these contribute to the impedance matching or amplification of sound in the middle ear. Now, once I'll explain it in Hindi, प्लीज रिमेंबर. अब हमें क्या पता है कि इनर ईयर में क्या होता है? फ्लूइड होता है. कौन सा फ्लूइड? एंडोलिम्फ होता है और पेरिलिम्फ होता है. तो जब साउंड या वाइब्रेशंस उन फ्लूइड के थ्रू ट्रैवल करेंगे तो उनको रेजिस्टेंस ज्यादा मिलेगा या कम मिलेगा? डेफिनेटली जब फ्लूइड के थ्रू ट्रैवल करना है, जब तुम पानी में कूदते हो तो ज्यादा रेजिस्टेंस आता है ना. सो डेफिनेटली व्हेन द साउंड, जब उनको फ्लूइड के थ्रू ट्रैवल करना होगा तो ज्यादा रेजिस्टेंस आएगा. तो क्या हो जाएगा? उनकी इंटेंसिटी जो है वो कम हो जाएगी. तो डेफिनेटली अगर 100 डेसिबल्स का साउंड था, वो तुम्हें बस 70 डेसिबल्स का सुनाई देगा. तो ऐसा तो नहीं होना चाहिए. फॉर दैट रीजन क्या होता है, यूजुअली जो मिडल ईयर होता है ना, उसमें एम्पलीफिकेशन ऑफ साउंड किया जाता है. एम्पलीफिकेशन ऑफ साउंड मतलब जो इंटेंसिटी होती है साउंड की, उसको बढ़ाया जाता है. ओके, so that is what we do. We increase the intensity of sound. and वो कैसे करते हैं हम? बिकॉज मैलियस सबसे बड़ा बोन है, फिर इनके से फिर स्टीपीस है. तो यूजुअली बड़े सरफेस से छोटे सरफेस पे पूरे साउंड वेव जो है वो कॉन्सेंट्रेट हो जाते हैं, एंड दैट हेल्प्स इन एम्पलीफिकेशन ऑफ साउंड. So just remember, important thing, impedance matching is what is the main function of middle ear. That will be your question. That's it. Now, if I talk about the walls of middle ear, if I talk about the roof of the middle ear, I'll just once draw it, so it will be much easier for all of you to understand. Okay. So this consider as your middle ear, definitely. Then this is what is your mastoid bone. This is your mastoid bone. This is the main vein of the cranial fossa coming outside. This is the main vein of the cranial fossa. I'm speaking in both the languages. Don't worry about that. Okay, we need to be considerate about the people who are not comfortable in English also, right? That's the reason why whatever I'm spoken, like whatever told you in English, that I've just repeated in Hindi as well. This is what is the main sinus or the main venous drainage. Okay, so this is what is the middle ear or the middle ear cleft looks like. This is the middle ear. Now this is what is the mastoid bone, and we know that in mastoid bone definitely we have small spaces. These small air filled spaces are called as air cells. So these are mastoid air cells, and the largest mastoid air cell we know it is called as the mastoid antrum, and this mastoid antrum is connected to the upper part of middle ear known as epitympanum. So this largest mastoid air cell is what is called as the mastoid antrum. Okay, and this connection is what is called as the adytus. Okay, that is important. Then this part which is there, it is called as the petrous apex, and in petrous apex also we have some air cells. Okay, in petrous apex also we have air cells. Okay, and close to the petrous apex we have two important nerves which are traveling. Okay, we have two important nerves which will travel. It is the fifth and the sixth cranial nerve. It is the fifth and the sixth cranial nerve. Okay, important is this is the middle ear. Above the middle ear we have this. What is this? This is the dura mater. That is the outermost meningeal layer. Now this is the dura mater. So you can see above the roof of the middle ear we have this dura mater of the brain. Okay, we have the dura mater of the brain. Below the floor of the middle ear, what you are able to see, this is the sinus, the main vein. It is known as the sigmoid sinus. This sigmoid sinus comes beneath the middle ear and it forms a dilatation, and this dilatation is what is called as a jugular bulb. And finally when it exits via the foramen, it will form the internal jugular vein. Okay, it will form the internal jugular vein. So you can see below the floor of the middle ear, definitely there is a dilatation of the sigmoid sinus known as the jugular bulb. Okay, so all of this you need to remember because it is very important to understand the infections as well. So if I talk about the roof, definitely the roof of the middle ear is formed by a bony plate, and that bony plate is called as tegmen tympani. And what lies above this bony plate or tegmen tympani? So above the tegmen tympani, definitely we have the dura mater. Above this we definitely have the dura mater of which lobe of the brain? Definitely above the ear we have the temporal lobe of the brain. Okay, so इसके ऊपर क्या होगा? तो temporal lobe होगा और उसका बाहर वाला meningeal covering होगा, that is dura mater. Next is floor. Definitely if I talk about the floor of the middle ear, so the floor is usually formed again by a bony plate that does not have a specific name usually, but below the bony plate of the floor usually we have a jugular bulb. So below the bony plate of the floor we have the jugular bulb. Next is the anterior wall. On the anterior wall of the middle ear we have two openings. Okay, on anterior wall of the middle ear we have two openings. One opening I have been drawing for a longer period of time now, which connects the middle ear to the nasopharynx. And what is this opening called as? So the lower opening which is there, it is for the eustachian tube. Okay, so the lower opening which is there, it is for the auditory tube, also known as the eustachian tube. Whereas the upper opening which is there, okay, there is another upper opening over here, and this upper opening which is there now, so please remember it is for the entry of a muscle. And which muscle enters from here? It is the tensor tympani muscle. It is the tensor tympani muscle which enters from the anterior wall of middle ear and goes and attaches to the malleus, innervated by, this was also a question, it is innervated by the mandibular nerve, and mandibular nerve I'll write it as V3. That is the third division of your trigeminal nerve. It is innervated by the mandibular nerve. Next is the posterior wall. So posterior wall which is there now, important is posterior wall has a bony projection, and that bony projection over the posterior wall which is there, it is known as the pyramid. And which is the another muscle which will enter from the pyramid? There are only two muscles in the middle ear, we have discussed that. So from this bony pyramid over here, another muscle will enter, and that muscle is known as trapezius. Okay, so via pyramid definitely another muscle enters known as trapezius. Okay, and this trapezius is attached to the stapes and it is innervated by the seventh cranial nerve or your facial nerve. ठीक है, तो जो पोस्टीरियर वॉल होती है उसके ऊपर एक बोनी प्रोजेक्शन होता है, उसको बोला जाता है पिरामिड, और उसमें से एक मसल एंटर करती है स्टेपीडियस, जो जाके कहाँ अटैच करेगी? स्टेपीज को, एंड इट इज इनर्वेटेड बाय द सेवेंथ क्रेनियल नर्व. दिस इज इंपॉर्टेंट, द इनर्वेशंस आर इंपॉर्टेंट. Next is the lateral wall. Lateral wall I have discussed in detail. So lateral wall of the middle ear which is there, it is nothing else but the tympanic membrane. Yes, so this is the lateral part now. So you are entering from the pinna, then you are going into the external auditory canal, then you are facing the tympanic membrane. So the tympanic membrane is the lateral wall of the middle ear. You are opening up the tympanic membrane and you are entering inside the middle ear. Exactly in front of you, you see the medial wall. Behind the medial wall lies the inner ear definitely. Okay? And usually on this side you will see the anterior wall and the two openings, and on this side you will see the posterior wall with the bony projection known as pyramid. Okay? So that's the important thing. So definitely if I talk about this medial wall now, behind medial wall we know we have the inner ear. Behind the medial wall we have the inner ear definitely. This medial wall has two windows because we need connection with the inner ear now. So it has two windows definitely. One window is called as the oval window. And क्या attached होता है oval window पे? What is attached at the oval window? So at the oval window we have the foot plate of stapes which is attached. Okay. So at the oval window we have the foot plate of stapes which is attached. And second is called as the round window. Second one is known as the round window. And this round window is covered by the secondary tympanic membrane or the round windowed membrane. Okay. So please remember the round window which is there, it is covered by the secondary tympanic membrane or the round window membrane. That is important. Next is projections. If I say there are two projections on the medial wall as well. These projections are nothing but the structures which are present inside the inner ear. Their projections are usually seen. One is what is called as a promontory. So promontory is nothing but a projection of basal turn of cochlea. We will talk about that. So just remember, promontory is nothing but the projection of basal turn of cochlea. Whereas another is important one. It is called as the lateral semicircular canal ka bulge. The other one is known as lateral semicircular canal bulge. So these are the important walls of your middle ear. Very important. Okay. So once you understand this, everything becomes easier. Now next question to you, all of you, is a child comes with complaints of heaviness in the ear with hearing loss. There is no pain as such, but the child is having heaviness in the ear. Along with that, the child is also complaining of hearing loss. He is also having poor school performance. Poor school performance we yesterday saw in adenoid hypertrophy, right? So something related to that might be. Okay, what is the diagnosis in the child and what is the treatment? And this is the otoscopic examination. Okay, this is what is the otoscopic examination. ठीक है, बच्चे में heaviness है कान में, hearing loss है, poor school performance है. Please tell me the diagnosis, guys. Please tell me the diagnosis. जल्दी से डायग्नोसिस बता दो यार. Faster. What is the diagnosis in this condition? Nobody? A child, usually a school age child, comes to you with hearing loss, heaviness in the ear, poor school performance. What has happened? This is your middle ear. This is your eustachian tube. This is the nasopharynx. In nasopharynx, what can happen in this child? As the child has recurrent upper respiratory tract infections, very good, there will be hypertrophy of the adenoids, and these hypertrophied adenoids will block the eustachian tube opening. If the eustachian tube opening is blocked, there will be collection of fluid inside the middle ear. The drainage of secretions will not happen. Therefore, all these secretions will collect inside the middle ear, and that will lead to a condition known as glue ear, also known as serous otitis media. ठीक है, तो क्या होता है बच्चे में, इफ देयर इज अ स्कूल एज चाइल्ड, हमने कल डिस्कस किया था, देयर कैन बी हाइपरट्रॉफी ऑफ द एडिनॉइड्स. उन हाइपरट्रॉफिड एडिनॉइड्स की वजह से जो तुम्हारी स्टेचन ट्यूब की ओपनिंग है ये ब्लॉक हो जाएगी. एंड इफ द स्टेचन ट्यूब ओपनिंग इज ब्लॉक, डेफिनेटली जो भी सिक्रीशन है मिडल ईयर के, दे विल नॉट बी एबल टू ड्रेन इनटू द नेसोफैरिंक्स, और उसकी वजह से वो जमा होते रहेंगे मिडल ईयर में, एंड दैट विल कॉज हियरिंग लॉस. क्यों? Because now the sound waves or the vibrations, they need to travel via the fluid, and I've told you fluid will give more resistance. Okay, ज़्यादा दिक्कत आएगी fluid को travel करने में, fluid के through travel करने में. Therefore, the patient will complain of hearing loss because now the vibrations or the sound waves needs to travel via the fluid. ठीक है? So here definitely the diagnosis is glue ear, and this glue ear is also known as serous otitis media. Why serous? Because it is a non-infective condition. Here there is no infection as such. It is not an infective fluid, it is a serous fluid. So serous otitis media, secretory otitis media. Nowadays the new name which will come in your examination is usually otitis media with effusion. Okay, so the new name of this disease is otitis media with effusion. Get acquainted to this term. Okay, this might be there in your options. Okay, that's important. So usually the same thing. Now what happens over here, there is a thick glue like fluid. Okay, there is a thick and sterile because as I've told you, definitely there will not be any infection now. So there will be a thick sterile glue like fluid in the middle ear of this child, and due to that the child will have all these complaints. There will be heaviness of the ear, there will be hearing loss in the child. Usually which kind of hearing loss will be there? Definitely as there is some problem in the middle ear, there is problem in the conduction of sound, definitely. So the patient will have a conductive hearing loss. Along with that, as the child is not able to hear properly, he is not attentive in class, and therefore a poor school performance will be there. Okay, so yesterday I've told you about this. What is done for investigation? Now, if any patient comes to me with complaints of hearing loss, any patient coming to me with complaints of hearing loss, First, I will send the patient for a PTA, that is a pure tone audiometry. On pure tone audiometry, definitely I'll get 10 to 40 decibels of conductive hearing loss. I will get a 10 to 40 decibels of conductive hearing loss. And what is done for treatment? We have discussed that yesterday already. Okay. If I do otoscopy examination, this was a previous year question of NEET PG 2022, where there was such an image which was given in the examination. You can see here there is no problem with the tympanic membrane. Okay. So there is some fluid collection behind the tympanic membrane, and in that fluid you are able to see these bubbles. In that fluid you are able to see all these bubbles over here. Okay. So definitely this is a case of groove ear or serous otitis media. Okay, where are all these bubbles which are present in the fluid behind the tympanic membrane. So this is a close differential diagnosis from bullous myringitis. What did I tell you? In bullous myringitis, there is infection of the tympanic membrane which causes bulla or bleb formation on the tympanic membrane. So these are not bulla or blebs, these are the bubbles which are seen behind the intact tympanic membrane. Okay, that is important to be remembered. If I talk about the treatment is this one. What is done over here? Now all that fluid has to be drained. Okay, पूरा fluid जो जमा है उसको निकालना तो है ही. Therefore, we will give an incision on the tympanic membrane, and if we give incision on the tympanic membrane, that is called as myringotomy. That is what is known as myringotomy. Okay, along with myringotomy, what I'll do after I drain all the fluid, then I'll insert a middle ear ventilation tube, and that middle ear ventilation tube, as you can see over here, this is what is called as a grommet. So I'll go for a grommet insertion as well. I'll go for a grommet insertion also. Okay, so that has to be done. With or without adenoidectomy. If the cause behind groove ear was adenoid hypertrophy, so definitely adenoidectomy has to be done as well. Moving further, next question is, a 25-year-old female complains of gradually progressive bilateral conductive hearing loss. She complains of gradually progressive bilateral conductive hearing loss. She is a young female, that's important. But she mentions worsening of symptoms since she has been pregnant. Okay, the symptoms have worsened since she has been pregnant. What is the diagnosis over here? This is a classical question, Sarkari. Okay, 25-year-old young female, gradually progressive, मतलब धीरे धीरे progress हो रहा है. Bilateral conductive hearing loss. That means there might be some problem in the external or middle ear. Then the patient has a conductive hearing loss. If there is some problem in the inner ear, patient has a sensory neural hearing loss. Okay? And there is worsening of the symptoms since she has been pregnant. What is the diagnosis? What is the diagnosis of this condition? Very easy diagnosis. What is your diagnosis, guys? It is a case of otosclerosis. Very good. Yes, it is a case of otosclerosis, definitely. And what happens in the case of otosclerosis? Sclerosis का मतलब होता है fibrosis. So we know that the foot plate of the stapes is attached to the oval window. Okay. So definitely, if there is fibrosis all around this foot plate of stapes, there is fixation of the stapes foot plate. Okay. So if there is fibrosis, definitely all around the foot plate of the stapes, there will be fixation of the foot plate of stapes. And if there is fixation of the stapes, can stapes move? Normally, for conduction of the sound, the stapes has to move in this piston-like manner. अगर conduct करना है sound, तो piston-like manner में stapes को move करना पड़ता है. But now there is fibrosis of the stapes. Therefore, the stapes is not able to move. Okay, therefore the conduction of sound will not happen, and therefore the patient will suffer from conductive hearing loss. Okay, that is what is seen. This condition is known as otosclerosis. It has some genetic predisposition. The pattern of inheritance is autosomal dominant. The pattern of inheritance is autosomal dominant, that you need to remember. Okay, it is usually common in young females, usually in their third or fourth decade of life. Okay, second, third or fourth decade of life. It is usually common in the young age group females. Important is, what is the aggravating factor? Aggravating, that means worsening factor. Which condition will lead to worsening of symptoms or aggravation of symptoms? That is what is pregnancy. So please remember, pregnancy will cause worsening in the patient. Okay, and the patient's main complaint will be a gradually progressive. This will never change. ये constant रहेगा तुम्हारे question में. The patient's complaints will be gradually progressive bilateral conductive hearing loss, because it will not occur only in 1 year. Fibrosis will occur in both the years. Okay, because it is a genetic condition. Okay, that's important. So usually, if I examine this patient, if the patient is in the early or the active stages of disease, so if the patient is in the early or active stages of the disease, I'll be able to see this important finding. And what is this important finding? You are able to see on the tympanic membrane, there is a pinkish appearance. This pinkish appearance of the tympanic membrane is called as the flamingo pink appearance, also known as which sign? Please let me know in the chat box. Okay, it is known as the flamingo pink appearance, or which sign it is called as. It is only seen in active stages of otosclerosis. Okay, so it is also known as which sign? Let me know that. Apart from this, when I ask the history to the patient will classically give me a history that she can hear better in noisy areas. Okay, yes, she is able to hear better in noisy areas, and that phenomena is called as paraacusis villi. That phenomena is known as paraacusis villi. Usko noisy areas में अच्छे से सुनाई देता है. Okay, so that is what is paraacusis villi. It is the phenomena which is seen in cases of otosclerosis. That's important. Okay. So very good all of you. This flamingo pink appearance or the pinkish appearance is known as the Schwartz sign. Okay, very good. It is known as the Schwartz sign. Now all of you will tell me that only 10% cases who come to me are in the active stages or early stages of the disease. Who will show us the flamingo pink appearance or the Schwartz sign? These patients are treated differently. Yes, these 10% cases, if they are showing the flamingo pink appearance or the Schwartz sign, these cases are treated differently. What is the treatment of choice for this patient? What is the treatment of choice for this patient? Okay, if I perform as the patient is having conductive hearing loss, I will go for a PTA, pure tone audiometry. On the pure tone audiometry, as you can see, this is what is air conduction. We know in cases of conductive hearing loss, the air conduction will be poor, whereas this will be the bone conduction. You can see the bone conduction will be normal. Okay, so air conduction is poor, bone conduction is normal, and in bone conduction you can see a dip, and this dip is usually seen at how many hertz? This dip is usually seen at around 2000 hertz. Okay, so this dip which is seen on an audiogram at 2000 hertz in bone conduction, this is what is called as the Carhart's notch. This is characteristically called as the Carhart's notch. So Carhart's notch is a specific feature seen in cases of otosclerosis on an audiogram where there is a dip in the bone conduction at 2000 hertz. That's important to be remembered. This is a Carhart's notch. What is the treatment of choice for the Schwartz sign positive patients? No. Overall, if you ask me what is the treatment of choice for otosclerosis, overall, definitely I'll say the treatment of choice. The better treatment is definitely a stepidotomy, nowadays done with a laser. Okay, stepidotomy. If that is not possible, if you are not able to save the stapes, then definitely stapedectomy has to be done. But preferred one is stepidotomy. But these are for the 90% patients who are in the later stages of the disease, fibrosis wale stages. But those who are the 10% cases in the active or the early stages of disease with Schwartz sign positive, here we will give an oral drug which will cause stabilization of the disease, and that is known as oral sodium fluoride. That has to be given. Okay, oral sodium fluoride. And if the patient is unwilling for the surgery, definitely in that conditions you can also give a hearing aid to the patient. Okay. Next, what is this? This is definitely is called as the Pulitzer bag, and this is what is method is known as Pulitzerization. What you can do with this? So definitely this Pulitzer bag which is there, or this method of Pulitzerization, it is used to check the patency. It is used to check the patency or the blockage of the eustachian tube. So please remember, it will help you to check the patency or the blockage of eustachian tube. Okay, with one hand you will press this bulb, and with other hand you will see the tympanic membrane of this patient. When you press this bulb, definitely what will happen? The air pressure inside the nose will change, the air pressure inside the nasopharynx will change. That is the reason why the air pressure inside the middle ear should change. Why? Because the eustachian tube is connected to the nasopharynx and the middle ear. Therefore, if you are changing the air pressure of nasopharynx, the air pressure of middle ear should change, and therefore the tympanic membrane should move. But if you are able to see that the tympanic membrane is not moving at all, that means the eustachian tube has been blocked. That is the reason why the changing air pressure is not transmitted to the middle ear. जो air pressure change कर रहे हो ना, वो middle ear तक नहीं पहुंच पा रहा because your eustachian tube is blocked. In that condition, you will not see any movement of the tympanic membrane. Okay, so that's important. If I talk about the eustachian tube, I hope all of you are quite aware. It is also known as the auditory tube. As we have discussed many a times, it is a connection between the middle ear and the nasopharynx. It is horizontal at birth, but then in adults usually it has an angle. You can see I have always drawn it on an angle. So usually it is an angle of 45 degrees with the horizontal. Okay, it has an angle of 45 degrees with the horizontal definitely. Okay, and it is 36 mm in length. Please remember, it is 36 mm in length. Out of which, if I talk about the lateral 1/3, it is usually bony. Okay, the lateral 1/3 is usually bony, but the inner 2/3 which is there, which is connected to the nasopharynx, the inner 2/3 is cartilaginous. That has to be remembered. Okay? And what are the functions of your eustachian tube? As I've told you, one was drainage of the middle ear secretions. Whatever secretions are produced in the middle ear, they are to be drained in the nasopharynx, and that is what is done with the help of eustachian tube. Second was what? Middle ear ventilation. Yes, it helps in maintaining the ventilation in the middle ear. And third is maintenance of air pressure in the middle ear. Okay, third was maintenance of air pressure inside the middle ear. These are the important functions of the eustachian tube. 3 important functions you need to remember. Moving further. Now this condition says what? A patient comes with complaints of severe earache. He also has fever. On examination, the below given appearance is seen. What is the management? This is the below given appearance. Patient is having severe earache. What is the diagnosis first of all? Tell me the diagnosis. Tell me the diagnosis in this condition. Patient is having severe earache. He is also having fever. And on otoscopic examination, such kind of appearance is seen. क्या दिख रहा है इस appearance में? Here you can see on the tympanic membrane, you can see that the blood vessels have been dilated. Okay, and these dilated blood vessels usually they look like the spokes of a wheel. What is this called as? This is characteristically called as the cartwheel appearance. It is known as the cartwheel appearance. Okay, so it is due to the inflamed tympanic membrane. There is inflammation of the tympanic membrane which is causing this cartwheel appearance as well. What is this diagnosis? This is a case of ASOM. Please remember, this is a case of ASOM, acute suppurative otitis media. What is otitis media? Infection of the middle ear. And why it is suppurative? Because there is pus formation in the middle ear. Therefore, it is called as a suppurative infection. Acute because the patient will come to an emergency with severe signs and symptoms. Okay? So therefore, it is a case of ASOM. The characteristic finding on otoscopy will be this cartwheel appearance. Main complaint of the patient is earache only. Okay? What should be done in this condition? What should be the management? The most common cause of ASOM is definitely strep pneumonia. The most common cause of ASOM is definitely strep pneumonia. It is a bacterial infection. That is the reason why. What should be the treatment? Definitely antibiotics. So if a patient is only showing you cartwheel appearance, the treatment should only be antibiotics. But what is done in this condition? Now, please let me know. Same patient, but the appearance is different. The patient is having earache, the patient is having fever, and on otoscopy, this kind of appearance is seen. What is the treatment or management in this condition? This was a previous year question. Let me know that in the chat box. Fast. Okay, let me know that fast in the chat box. Please let me know this. Jaldi se. What is done for treatment in this condition? What is done for treatment in this condition, guys? जल्दी से बताओ. What is done for treatment? So please remember, what is the basic difference over here? Here you can see it is a full or a bulging out tympanic membrane. Why there is a full or a bulging out tympanic membrane? Because there is a lot of pus behind the tympanic membrane. You can see now all of this is a pus, and there will be a risk of rupture now. If you do not treat now, if you do not treat the patient now, if you do not treat or give an incision and drain all the pus, the tympanic membrane is going to rupture and then it will not heal. Because I've told you, the perforations or rupture which will occur due to infection, they will not be self-resolving. Okay? So that's the problem. So in this condition, if it is a full or a bulging out tympanic membrane, in this condition you have to perform a myringotomy. That means you need to give an incision over the tympanic membrane and you need to drain the pus. You need to drain the pus. That is the important thing, guys. Okay? So that's the basic difference between a cartwheel appearance and a full or a bulging out tympanic membrane. Okay? Both are cases of ASOM, but the management is different in both of them. That's important. Okay? Next, if I talk about if ASOM was not treated, what will happen? As I've told you, if ASOM is not treated, what will happen? There will be a full and bulging out tympanic membrane, and finally it will rupture. And when there will be a rupture or a perforation, there can be a central perforation. And if the central perforation remains over there for a span of 3 months, then it will become a permanent perforation, and then the patient will suffer from a chronic otitis media, and that one is called as a safe CSOM. If a patient has a central perforation, he will suffer from safe CSOM, whereas if the patient has a marginal perforation, he will suffer from unsafe CSOM. That's the important thing. Please remember. Okay. So here definitely there will be a central perforation which will further cause safe chronic suppurative otitis media in the patient. If I talk about safe CSOM, it is also known as, please remember, it is also known as tubotympanic CSOM. Why tubotympanic? Because here the infection is only limited to the eustachian tube and the tympanic cavity or the middle ear cavity. Therefore, it is known as a tubotympanic CSOM. Okay? So that's the important thing over here. Important is what will be the complaint of the patient. Definitely the complaint of the patient will be earache because it is a bacterial infection. Apart from that, the patient will have a ear discharge. Which kind of a ear discharge will be present in the patient? So here the patient will have a lot of ear discharge, profuse, that to mucopurulent, that is mucus plus pus containing ear discharge will be there in the patient. Okay? So this ear discharge will be present in the patient usually. Okay? Apart from that, the patient will definitely have hearing loss as well. Apart from that, the patient will also have hearing loss. And which kind of hearing loss will be there? Definitely the patient will have conductive hearing loss. Why? Because the problem is lying in the middle ear. Therefore, there will be problem in the conduction. What should be the treatment in the case? What should be done for treatment? On otoscopic examination, if you perform, you will be able to see a central perforation. A PTA, pure tone audiometry, will show you that the patient is suffering from a conductive hearing loss. Okay? What should be done for treatment? So for treatment, definitely we will go for, okay, for treatment definitely we will go for a surgery. And what is that surgical management called as? So please remember, if the ear ossicles are not damaged, how you are getting to know that the ear ossicles have been damaged or not? With the help of a CT scan. So yes, you need to get a CT as well. Okay, proper CT has to be done. So on the CT scan, you need to check if the ear ossicles have been damaged or not. And why the ear ossicles will damage? Because there is infection in the middle ear now. So that will also damage the ear ossicles. Okay, so there will be erosion of the ear ossicles. One important question to all of you: which is the most common ear ossicle eroded? Which is the most common ear ossicle eroded and why? Which is the most common ear ossicle eroded and why? That is your question. Please let me know in the chat box. Okay, so definitely, as the ear ossicles, if the ear ossicles are safe completely, if they are not eroded, there is no problem in the ear ossicles, then only we need to repair the tympanic membrane, because the tympanic membrane has been ruptured. That is what is called as myringoplasty. Okay, if the tympanic membrane are absolutely fine, only go for a myringoplasty, that is repair or reconstruction of the tympanic membrane. It is nothing else but a type 1 tympanoplasty. Yes, myringoplasty is nothing but a type 1 tympanoplasty. But if the ear ossicles have been eroded, okay, then we need to go for a type 3 tympanoplasty. Where we will go for repair of the whole middle ear cavity. We'll go for repair of the whole middle ear cavity. That's important. Okay, so please remember, type 3 tympanoplasty will be done usually in that patient. Okay, so that is what is done. Type 3 tympanoplasty is also known as myringostapediopexy. Why? Because in this condition, the malleus is eroded, the incus is eroded, the stapes is only present. That is the reason why what we do in the surgery, we remove the malleus, we remove the incus, and we actually take a graft of the tympanic membrane. And this new graft of tympanic membrane which is there now, it is usually placed directly over the stapes. We fix this tympanic membrane graft over the stapes. The tympanic membrane graft which is usually taken as the temporalis fascia, okay, and that is directly placed over the stapes. Therefore, it is called as myringostapediopexy or a type 3 tympanoplasty as well. Okay, so that will be done. Or if you feel that we should place some ear ossicles, if the normal ear ossicles are eroded, we should place new ear ossicle. Then the surgery that we perform is called as ossicular replacement prosthesis. Then the surgery we perform is known as ORP, ossicular replacement prosthesis. If it is a M minus I minus S plus situation, that means malleus is gone, incus is gone, stapes is there only, then we'll go for a partial ossicular replacement prosthesis known as POR. Okay, you can see it is smaller in size. But if it is a M minus I minus stapes head minus situation, that means only the foot plate of the stapes is left. In this condition, we need a longer prosthesis, and that is called as TOR, total ossicular replacement prosthesis. Okay, so that is what is done usually. Here also we need to place a new tympanic membrane graft as well. Okay, so that's the basic difference between both of these. Chalo. Next, if I talk about another one, that is unsafe CSM. If I talk about unsafe CSM, it is also known as atticoantral CSM. What did I tell you? What is an attic? Attic is nothing but sorry, the upper part of the middle ear, known as epitympanum also. So attic is another name for the epitympanum. And from there, the infection is spreading where? From there, the infection is spreading to the antrum. What was the antrum? Antrum was nothing but the largest mastoid ear cell. So here you can see the infection was in the middle ear. Now via this aditus, it has spread to the mastoid also, and mainly to the mastoid antrum. Therefore, now the infection is spreading beyond the middle ear, and therefore it is called as unsafe CSM. So unsafe ka matlab ye hai because it is spreading beyond the middle ear. Okay? So atticoantral CSM. Yes. Okay. So here not only the ear ossicles will be eroded, but here the walls of the middle ear will also be damaged, and the infection will spread out of the middle ear. Okay. Yes, all of you are right. Please remember. Okay. So the most common ear ossicle Definitely the one which is eroded is the incus. That was a previous year question. Why? Because it has no muscle attachment to it. As there is no muscle attachment to it, definitely, please remember, there will be decreased blood supply. Least blood supply will be there to the incus, and therefore there will be the higher chances of erosion of the incus. Please remember. Okay, so no issues with this, anybody? Now, if I talk about atticoantral or unsafe CSOM, please remember atticoantral or unsafe CSOM. Please remember here, as I've told you, the infection will spread beyond the middle ear. It will spread beyond the middle ear, and mainly it will spread to the mastoid and from there to all the other sites as well. Okay. Important is an unsafe CSOM also. What was the cause? As I've told you, central perforation will cause safe CSOM, but a marginal perforation will cause unsafe CSOM. Marginal perforation will cause unsafe CSOM. Apart from this, what are the other causes? If there is a retraction of the tympanic membrane, so there will be retraction of the tympanic membrane, as I've told you, and in that retracted tympanic membrane, what will happen? It will keep on retracting, and it will finally rupture. As it will finally rupture, what will happen? The skin of the external ear will grow inside the middle ear, and if the skin of external ear grows inside the middle ear, that is what is called as cholesteatoma. Okay, so due to excess of retraction, there will be rupture, and finally there will be a formation of cholesteatoma. Okay, or this cholesteatoma, that is skin in the middle ear, will be present since birth itself. That is called as a congenital cholesteatoma. So there can be various causes of cholesteatoma. If they say there is a pearly white mass behind an intact tympanic membrane in a child since birth, then it is a case of congenital cholesteatoma. That was a previous year question. If they say that there was a retraction of tympanic membrane which has undergone a perforation and therefore there is a formation of cholesteatoma, it is called as a primary acquired cholesteatoma, which is the most common type of cholesteatoma. Next, if they say there was a ASOM in the patient due to which the patient developed a marginal perforation and due to which now there is presence of skin inside the middle ear, that is a case of secondary acquired cholesteatoma. Okay, so that's important. Most common is primary acquired, and this is what is a cholesteatoma. You can see a pearly white mass usually in the middle ear cavity. This is a case of cholesteatoma. And why this is important? Because this cholesteatoma has bone eroding properties. It will cause erosion of the bone, and mainly which bones will be eroded? The walls of the middle ear will be eroded, and therefore the infection will not be limited to the middle ear. Now it will spread beyond the middle ear as well because of this cholesteatoma. Okay, what is the most common site for this cholesteatoma? You just need to remember it is in the upper part of the middle ear between the neck of the malleus and the pars flaccida, known as the Prosac space. So the most common site for this cholesteatoma is the Prosac space usually. Okay, it is the Prosac space. Now what will be the complaints of the patient? Just like unsafe CSOM, here also the patient will have, safe CSOM, here also the patient will have earache. Apart from that, here also the patient will have ear discharge. But what will be different? There the patient was having profuse ear discharge. Here the patient will have very small amount, scanty ear discharge. And here the ear discharge will be blood stained and it will be foul smelling as well. And why foul smelling? Because there is bone erosions as well. Okay. Apart from that, the patient will have conductive hearing loss also. Okay, more severe definitely. Now, if I talk about the treatment is definitely a surgery, and that is called as MRM. What is MRM? Modified radical mastoidectomy. It is not mastectomy, it is modified radical mastoidectomy, also known as a tympanomastoid exploration. It is the treatment of choice. Okay. Because here not only the mastoid, not only the tympanum or the middle ear is affected, but also the mastoid is involved. That is the reason why we will go for MRM or modified radical mastoidectomy, also known as tympanomastoid exploration. Now please let me know, what is the most common complication of your CSOM? The most common complication of your unsafe CSOM is usually acute mastoiditis. The most common complication of unsafe CSOM is definitely acute mastoiditis. Please remember that. Okay. It is also the most common extracranial complication, because there can be some intracranial, some extracranial complications also. The most common complication of unsafe CSOM is usually acute mastoiditis. Please remember that. Okay. Whereas if they ask you which is the most common intracranial complication, which is the most common intracranial complication of unsafe CSOM, answer is meningitis. The most common intracranial complication of unsafe CSOM is meningitis, definitely. That you need to remember properly. Okay. So as you can see over here, so from the middle ear, either the infection can spread backwards and it will cause mastoiditis, or it can spread upwards and it will cause meningitis. Okay. So that will be seen. That is important. Chalo. Now here I have a question. There can be other various complications as well. The patient will have abscess formation. There can be labyrinthine fistula. The patient can also have petrositis or Gradinigo syndrome. The patient can also have subdural empyema or a brain abscess or an extradural abscess, sigmoid sinus thrombosis. All of these are complications. All of you are quite aware of that. Now, answer this question. A person had a history of CSOM. Now he has been brought to the emergency room with altered sensorium. There is seizures and there is confusion. MRI has been given below. What is the likely diagnosis? So this is the MRI which has been given below. You can see somewhere in the temporal lobe, definitely you are able to see some lesion. Okay, so what is your likely diagnosis of this condition? Definitely it is a complication of CSOM because the infection has spread from the middle ear to the brain now, and in brain it is causing some problem, and therefore the patient is having altered sensorium, seizures and confusion like neurological features. MRI shows a lesion in the temporal lobe. What is the diagnosis in this condition? What is the diagnosis of this condition, guys? What is the diagnosis of this condition? Anybody? Let me know this. So please remember, it is a case of brain abscess. Okay, it is a case of brain abscess, and the brain abscess which occurs due to ear infection, it is also called as autogenic brain abscess. Okay, it is also known as autogenic brain abscess as well. Okay, and what is the most common site for autogenic brain abscess? The answer is clear. It is definitely the temporal lobe. Please remember. So treatment of the complications of unsafe CSOM. If they ask you what is the treatment of complications of unsafe CSOM, for all of the complications of unsafe CSOM, the treatment, okay, the treatment is usually MRM itself, that is modified radical mastoidectomy. Okay, it is the same except for two conditions. And which are these two conditions where a ENT surgeon cannot operate? And these are usually a case of brain abscess, or it is a case of subdural empyema. It is either a brain abscess or it is a case of subdural empyema. Okay, empyema is again a pus collection only, but beneath the dura mater. Therefore, it is called a subdural empyema. In these two conditions, definitely the patient will need a neurosurgery. In these two conditions, the patient needs a neurosurgery. That's important. Next, this is also one of the complications of the unsafe CSM. What you can see, there is usually a swelling in the neck of this patient, and this swelling we can see it is along the sternocleidomastoid muscle. So here you can see there is a pus collection along the sternocleidomastoid muscle. This abscess which is formed along the anterior border of sternocleidomastoid muscle is known as the Basalt's abscess. This is a case of Basalt's abscess. Okay, so if there is abscess formation or pus collection along the sternocleidomastoid muscle, that is what is called as Basalt's abscess. If the pus collection occurs inside the external auditory canal, if the pus collection occurs inside the external auditory canal, it is called as the Lux abscess. Okay, it is known as the Lux abscess. If the pus collection occurs along the digastric muscle, here we have the digastric. अगर यहाँ पे swelling होती, if the patient has swelling over here along the digastric muscle, if there is abscess formation along the digastric muscle, then definitely it is called as the Sitzley's abscess. Then it is known as the Sitzley's abscess. Okay. Whereas the most common site for this abscess formation, usually the most common site for this abscess formation is post-auricular. What is post-auricular? Behind the pinna. And what is over here? Mastoid. So the most common site for this abscess is definitely a mastoid abscess. Most common site for abscess formation after unsafe CSOM is definitely mastoid area. Okay, that is important to be remembered. Next question, it says a patient was diagnosed as a case of CSOM, chronic suppurative otitis media, and the fistula test was positive. Okay, fistula test was positive, but it denies any kind of treatment, and he returns after 2 months with worsening of hearing loss. With worsening of hearing loss. This was a previous question. On examination, the fistula test is negative. What is the likely cause of the condition? And Rene will be. Okay. Now let's understand this question. So the patient is a case of chronic suppurative otitis media, and when he came to us, the fistula test was positive. What is done in the fistula test? Please remember, we will use a Siegel speculum. Okay, we will insert the nozzle inside the ear, and then with the help of a bulb, you will keep on changing the pressure inside the external auditory canal. When you change the pressure inside the external auditory canal, this changing air pressure will not cause any problem in you, because this changing air pressure is not directly reaching the semicircular canal. Therefore, you will not experience any kind of vertigo. But in case if a patient is having CSOM, that means there is tympanic membrane perforation, and along with that there is also labyrinthine fistula which is formed. Labyrinthine, that is the inner ear fistula which is formed due to the damage of the medial wall of the middle ear. Therefore, this air pressure which is increasing or decreasing, it is directly reaching to the lateral semicircular canal. It is directly reaching to the lateral semicircular canal. This changing air pressure is causing disturbance in the lateral semicircular canal, and that is the reason why the patient experiences vertigo. This is what is called as a fistula test. So now fistula test will only be positive if there is this labyrinthine fistula. Okay, this fistula test is only positive when there will be a labyrinthine fistula in the patient. So definitely here the patient was a known case of CSOM, and therefore he has developed a labyrinthine fistula as a complication, due to which the fistula test is positive now. But now he denies the treatment and returns after 2 months, as he has not taken the treatment, and he is coming to you after 2 months with worsening of the hearing loss. Definitely what has happened, the infection has increased, and now the infection has also spread from the middle ear. The infection has also reached to the inner ear as well. And what has happened to the inner ear? The inner ear has been completely damaged now. The inner ear is completely dead. Okay, so there is a dead inner ear. Now, if there is a dead inner ear, will it respond to any air pressure change? No. Now, when you try to check the fistula test in this patient, okay, even you increase or decrease the air pressure, the patient is not having any kind of vertigo. Why? Is the fistula have repaired itself? No. The problem is now the inner ear has been dead, and as the inner ear has been dead, that is the reason why it is not responding. Okay, that is the reason why the fistula test is coming out to be negative. So is it a true negative fistula test or a false negative fistula test? So definitely it is a false negative fistula test. So please remember, it is a false negative fistula test. The false negative fistula test is seen in two conditions. One, when there is a dead inner ear, therefore the patient does not experience any vertigo. And second, when the fistula is covered by cholesteatoma. When the fistula which is there now, it is covered by a cholesteatoma. Therefore, the air pressure is not able to reach the lateral semicircular canal. Therefore, the patient is not having any vertigo. Okay, so that is the two conditions. Okay, so the likely cause is usually a dead inner ear in this patient. That's the problem. And what will be the Rhine in this patient? If a patient is having a dead inner ear, the patient will have a unilateral severe sensory neural hearing loss. If a patient has a unilateral severe sensory neural hearing loss, the Rhine which is there, it will be false negative. The Rhine which is there, it will be a false negative Rhine. Okay, that is important to be remembered. This was a previous year question. They asked you this case and they asked you which type of Rhine will be seen. So you need to remember it is a false negative Rhine which will be seen. Okay. Next complication is what is this? That is a sigmoid sinus thrombosis. If I talk about sigmoid sinus thrombosis, guys, so sigmoid sinus thrombosis is also known as lateral sinus thrombophlebitis. What did I tell you? Thrombophlebitis is actually inflection of the vein. So yes, please remember that sigmoid sinus is also the main vein of your cranial cavity or main vein of your brain. Okay, so sigmoid sinus thrombosis or lateral sinus thrombophlebitis is nothing but the infection of the sigmoid sinus. Along with that, there is also blockage in the sigmoid sinus as well. There is thrombosis in the sigmoid sinus also, because the infection from the mastoid will further spread to the sigmoid sinus posteriorly, and that will cause sigmoid sinus thrombosis in the patient. If there is sigmoid sinus thrombosis, what will be the complaint of the patient? Definitely the intracranial, the blood is not able to come out from the brain now, from the cranial cavity. Therefore, the intracranial pressure rises, and that is the reason why this patient develops a headache. Okay, this patient develops a headache. Along with that, the patient develops a spiky fever, and that spiky fever is called as a picket fence fever. The patient develops a classical fever known as the picket fence fever. Along with that, definitely what will happen in the patient, along with headache and the picket fence fever, the patient will also have edema over the mastoid. And what is this edema over mastoid known as? Please answer me the name of this sign. The patient will have edema over the mastoid. What is the sign called as? Please let me know that in the chat box. Okay? There will be edema over the mastoid. Okay? So all of these features will be seen in the patient. Okay, all of these features will be seen in a case of sigmoid sinus thrombosis. Now, once what we will do for investigation, the investigation of choice in this condition, will be a CECT. It will be a contrast enhanced CT scan. Okay, CECT of head should be done, and on the contrast enhanced CT scan of head, as there is thrombosis in the sigmoid sinus, that part of the sigmoid sinus will not take up the contrast, and that is the reason why you will see a triangular appearance. This triangle looks like a Greek alphabet delta. Therefore, this CECT will show us the delta sign, also known as the empty delta sign. So the CECT characteristically shows us the delta sign or the empty delta sign. That is commonly seen. What is done for treatment? Definitely. So please remember, for treatment, again, for all complications of unsafe CSOM except two. I've told you the treatment is MRM itself, modified radical mastoidectomy. Along with that, we need to clear the thrombus as well. Along with that, we need to clear the thrombus as well. Anybody, what is the sign? Nobody has answered. Edema over a mastoid. It is known as the Grisenger sign. Please remember. This one is what is called as the Grisenger sign. Okay? This is what is called as the Grisenger sign. Okay? That's important to be remembered. Next is this condition now, which is the most common complication of ASOM or CSOM. What was the most common complication of ASOM or CSOM? I've told you it was acute mastoiditis. That means the infection has spread to the mastoid air cells now. So infection of mastoid air cells is called as acute mastoiditis. What will happen in this condition now? As the infection is also spread to the mastoid, now there will be a lot of space for pus to form. Therefore, there will be excess of pus which will be formed. Therefore, this patient will come to us definitely with profuse ear discharge. Okay, profuse is a lot of ear discharge. Okay, the patient will have a profuse mucopurulent ear discharge. Along with that, the earliest sign which will be there will be this. This is not a battle sign. You cannot see bleeding over here. This is the ironing of the mastoid surface because there is infection in the mastoid now. Therefore, there is inflammation of the mastoid that causes this ironing of mastoid surface. Okay, there will be ironing of mastoid. This is the earliest sign definitely for a case of acute mastoiditis. Okay. Along with that, I've told you the symptom will be profuse ear discharge. Apart from that, the patient will also complain of earache. Along with earache, the patient will also have a retroauricular pain because the infection is behind the pinnana. So the patient will have retroauricular pain as well. Okay. That's important. Retroauricular pain will also be there. Then if I examine the patient, okay, if I examine the patient by otoscopy, I'll be able to see these two important signs. One is called as the mastoid reservoir sign. What happens? What is reservoir? Reservoir means a talab. Okay? Talab जैसे कि pus भरा हो. Okay, so as soon as you clean the pus, immediately the pus fills again. Okay, why? Because there's a lot of space now for the pus to form in the mastoid. Therefore, the pus is forming and forming and forming. A lot of pus is there. Therefore, whenever you clean the pus, immediately it will fill up again. That is called as a mastoid reservoir sign. Okay. Next is lighthouse sign usually. What is seen? When you perform an otoscopic examination, the cone of light, as you can see over here, the cone of light or the light reflex, now it will keep on moving because there is pus behind the tympanic membrane. Therefore, there will be a moving light reflex that is known as the lighthouse sign. Okay? So these are the important things which will be seen. Then if I talk about the investigations, definitely as the patient will have hearing loss also, send the patient for PTA, pure tone audiometry. But important is take a X-ray mastoid of this patient. When you take a X-ray mastoid, it will be taken in two views. One is called as the anteroposterior view, that is known as the Towne's view, okay, of the X-ray. And second is called as the right and left oblique view, okay, right or the left lateral oblique view, that is known as the Schuller's view. Better view is definitely the Schuller's view because it covers more area. Schuller's view is better. Further confirmation, you can also go for a CT of mastoid. Treatment is what? Treatment is known as a surgery called as cortical mastoidectomy. Treatment is a surgery called as cortical mastoidectomy. You will clean the mastoid properly. Okay, that is called as cortical mastoidectomy. And this cortical mastoidectomy is also known as a Schwartz operation. So please remember this cortical mastoidectomy is also known as Schwartz operation. What is the first step in a case of cortical mastoidectomy? The first step is to find the largest mastoid air cell. And what is the largest mastoid air cell known as? The largest mastoid air cell is known as the mastoid antrum. So because maximum infection will be present in the mastoid antrum. So try to find the mastoid antrum usually. And what is the surgical landmark to find the mastoid antrum? So the surgical landmark to find the mastoid antrum, please remember, it is nothing else but the Mac-Evans triangle. It is nothing else but the Mac-Evans triangle, also known as the suprameatal triangle. Okay, it is also known as the suprameatal triangle. But in some patients, it will be very difficult to find the Mac-Evans triangle, or it will be very difficult to find the mastoid antrum. Why it will be very difficult to find the mastoid antrum? Because in these patients, there will be a bony septum which will be present. This is a remnant of the petrosquamous suture. This bony septum which is present is known as the corner septum. So usually if there is a corner septum in a patient, that will make it difficult to find the mastoid antrum usually. Okay? So that's the important thing. Last complication, then we'll take a break and then we'll start with inner ear. So this is known as Gradinego syndrome. Gradinego syndrome is when the infection will spread to these, as you can see over here. So when the infection was over here in the mastoid air cells, this was called as mastoiditis. But when the infection will be over here in the petrous apex air cells, that will be called as petrositis. And that petrositis is also known as Gradinego syndrome. That petrositis is also called as Gradinego syndrome. Important is this petrositis which is there. It is characterized by a three important triad. And what is this triad? It is remembered by the mnemonic RED. Okay, the triad of Gradenigo syndrome or petrositis is remembered by mnemonic RED, where R goes for retroorbital pain. And why there is retroorbital pain in the patient? Because of the involvement of fifth cranial nerve. I told you near the petrous apex air cells there are two important cranial nerves which will pass. Okay, one is called as the fifth cranial nerve or the trigeminal nerve. The other is called as the sixth cranial nerve or the abducens nerve. So due to fifth cranial nerve involvement, patient will have retroorbital pain. E stands for ear discharge. Definitely it is an infection and there will be pus formation. So definitely the patient will have ear discharge. And D stands for diplopia. Why diplopia? Diplopia is nothing but double vision. So double vision because of sixth cranial nerve involvement. Okay, sixth cranial nerve or abducens nerve involvement will cause diplopia in the patient. This is the characteristic triad. Treatment is the same treatment as MRM over here as well. Treatment is modified radical mastoidectomy, MRM over here. Okay. So let's take a break and let's meet up after 10 minutes. Okay, 10 to 12 minutes. Okay. Chalo. Welcome back, guys. Let's start with the last topic, and that is what is inner ear, and we'll discuss some important points about audiology as well. Okay? Chalo. Let's start from here. Kare start. Let me know. Give me a thumbs up. Give me a thumbs up. So if the audio visuals are clear, please let me know so I can just begin. Is it fine? Please let me know. If everything seems fine, please let me know. Hopefully now I'm audible. So let's start without any delay. Now let's talk about the inner ear. I've told you already there are three structures which are present in the inner ear. One of them is called as the cochlea. And this cochlea which is there, it is responsible for hearing, I told you. Okay, it is responsible for hearing. It is a sensory organ responsible for hearing. Whereas the other two which are there now, the one was called as utricle and saccule. The one of them was called as utricle and saccule. What is the function of utricle and saccule? That was a recent FMG question. The function of utricle and saccule is to maintain the linear balance of the body. Okay, the function of the utricle and saccule is to maintain the linear balance. When you walk straight, the balance of your body is usually maintained with the help of this utricle and saccule itself. Okay, that's important. Whereas if I talk about the semicircular canals, these semicircular canals which are there, they are also responsible to maintain the balance of your body, but they are responsible to maintain the angular balance of your body. That means when you take a turn, you will twist, okay? So you bend all of that time, you do not fall, right? So because the semicircular canals are responsible for maintaining the angular balance of your body. Okay, so these are the important things you need to remember. Now in the inner ear, as I've told you, usually there are two kinds of fluids in the inner ear. One is called as the endolymph, which is present inside the membranous inner ear. So you can see over here, we have a membranous inner ear and the outer covering is known as the bony inner ear. Okay, so the actual inner ear is this membranous inner ear and it is surrounded by a bony covering. Now the fluid which is present in the membranous inner ear, the darker fluid that you can see, it is known as endolymph. Okay, the darker purple fluid which is present inside the membranous inner ear, it is known as the endolymph. Whereas the darker brown fluid, the dark brown fluid that you can see in the bony covering, it is called as the perilymph. Why peri? Because it is surrounding the labyrinth or surrounding the inner ear. Therefore, it is called as perilymph. And why endo? Because it is inside the membranous inner ear. Okay? So that's the basic idea you need to remember. So important is, if I talk about the endolymph, this endolymph is secreted by, so please remember this endolymph is secreted by the stria vascularis. It is the lining of your inner ear known as stria vascularis. So endolymph is secreted by the stria vascularis and it is absorbed by the endolymphatic sac. Okay, so this endolymph it is absorbed by the endolymphatic sac. So it is produced or secreted by the stria vascularis and it is absorbed by the endolymphatic sac. That you need to remember properly. Okay, so that is important. No issues with this, anybody? Now if I talk about this question, so before that, just understand the anatomy once. Those who are having any issues with anatomy, so these are the various ones. The first part, as I've told you, it is a cochlea, and we know that cochlea is a snail-like structure. It is made up of turns. Okay, it is a snail-like structure made up of turns. How many turns are there in a cochlea? It is usually 2.5 to 2.75 turns. There are around 2.5 to 2.75 turns. मतलब 2.5 से 3.5 turn होते हैं. Okay, 2.5 to 2.75 turns are usually there. Then this cochlea which is there, you can see it is connected to the vestibule. And what is the vestibule? I've told you, utricle and saccule are present inside the bony covering, that is called as the vestibule. Utricle and saccule, they are present inside the bony covering known as the vestibule, and that is usually connected with the help of this ductus reunions. Okay, that is usually connected with the help of this ductus reunions. Okay, then this ductus reunions के बाद we have this saccule over here which is further connected to the utricle. So utricle and saccule are there. They are responsible for linear balance of your body and present inside a bony covering known as vestibule. And continuation of this utricle and saccule will be these three semicircular canals. This is the superior, just a minute. This is the superior semicircular canal. This is the posterior semicircular canal. and this is the lateral semicircular canal. Okay, so we have three semicircular canals, the posterior, superior and the lateral semicircular canal, and as you can see they are in different directions. Why? To maintain the angular balance of your body as well. Okay, now you can see that one end of the posterior and superior semicircular canal is fused together. So this fused end of the posterior and the superior semicircular canal is known as crus commune. It is known as crus commune. Whereas on the other hand, you can see that one end of each semicircular canal is dilated. हर एक semicircular canal का एक end जो है वो dilated है. One end of each semicircular canal is dilated. This dilated end of semicircular canal is known as ampulla. Okay, this dilated end of semicircular canal is known as ampulla. And this ampulla contains the sensory end organ of semicircular canal. And what is the sensory end organ of semicircular canal known as? This sensory end organ of semicircular canal is known as crista. Okay, the sensory end organ of semicircular canal is known as crista. Whereas what is the sensory end organ of utricle and saccule? So the green one that you can see, the sensory end organ of utricle and saccule is this one. It is the macula. Okay, the sensory end organ of utricle and saccule, it is called as macula. And what is the sensory end organ of your cochlea? So the sensory end organ of your cochlea is known as organ of Corti. Okay, the sensory end organ of cochlea is what is called as organ of Corti. That is basically responsible for hearing. No issues with this, anybody? So that's the important thing you need to remember. Now here we have a person who was admitted for meningitis. After a few days he develops deafness. What is the route of spread? So yes, all of you are right. Some of you have answered it. So please remember, definitely we have spoken about the one fluid that is known as endolymph, which is present inside the membranous inner ear, and inner ear is also known as labyrinth. Therefore, it is present inside the membranous labyrinth. Okay, that is produced by stria vascularis and absorbed by endolymphatic sac. But what about the surrounding fluid? That surrounding fluid is called as perilymph. And what is this perilymph? So perilymph is nothing else but the CSF itself, guys. Yes, so perilymph is nothing but the CSF. So when this CSF is present in the subarachnoid space, it is called as CSF, cerebrospinal fluid. But when that CSF comes into the inner ear, in the bony covering of inner ear, it will be called as a perilymph. Yes, so perilymph is nothing else but the CSF itself and the connection in between both of them. Okay, the CSF comes into the perilymph via this connection, and that is what is called as aqueduct of cochlea. Okay, so that is important. So please remember, that's important. You need to remember usually that the infection from the subarachnoid space can spread to the inner ear, or vice versa. The infection from inner ear can spread to the subarachnoid space as well. So here the patient was suffering from meningitis. That means he was having infection in the subarachnoid space. From there, the infection might have spread to the inner ear, and that has caused damage to the inner ear completely, and that is the reason why the patient has now developed deafness. Okay, so what is the route of spread? Now you know that route of spread is nothing else but the aqueduct of cochlea, also known as the cochlear aqueduct. Okay, here next we have a patient who complains of vertigo. What is called vertigo? Chakkarana. Okay, so the patient who complains of vertigo, which suddenly starts, okay, these vertigo suddenly starts when the patient gets up from bed or turns his head. Okay, so vertigo which will suddenly start will be called as paroxysmal vertigo. Okay, is it is it dangerous to the patient? No, it is a benign condition. So it is a case of benign, paroxysmal, and whenever the patient changes his position, then the patient experiences vertigo. So it is called as a positional vertigo. So this condition, the diagnosis of this case is what is BPPV. What do I mean by BPPV? Benign paroxysmal positional vertigo. Benign because it is not life threatening, it is not severe. Paroxysmal because it is sudden in onset. Positional because the patient experiences vertigo only when he turns his head or when he changes his position. Okay. Important is why BPPV will occur in a patient. So now, as I've told you, what is the sensory end organ of utricle and saccule? The sensory end organ of utricle and saccule is called as the macula. This macula usually has a gelatinous covering over its surface, and the gelatinous covering contains these calcium carbonate crystals. Okay, these contains this calcium carbonate crystals. Now these calcium carbonate crystals are also called as otoconia or otolith. And that is the reason why utricle and saccule can also be called as otolithic organs. That's the important reason. Now this otoconia or otolith which are there now, they are actually attached to this macula because of this gelatinous layer. But in some patients, what will happen? In some patients, this otoconia or otolith can turn free. Okay, ये खुले हो जाएंगे. And when they turn free, they will reach into the semicircular canal. And when they can reach into the semicircular canal, only when the patient changes his head position. And that is the time when these otoconia or otoliths reach into the semicircular canal, they cause disturbance in the semicircular canal. And that leads to vertigo in the patient. Okay? And that is what is the case of benign paroxysmal positional vertigo. Okay? So it is due to dislodgement. I'll just write it is due to dislodgement of otoconia. Important is what is done for diagnosis in this condition. It is this maneuver which is done for diagnosis. What do we do? Here you can see there is a doctor or an examiner in the image. Along with that, you can see there are only 2 steps in this maneuver. This is what is a diagnostic maneuver done for BPPV. So here we will pull the head of the patient suddenly back and we will turn his head towards one side. As soon as you pull the patient back and turn his head towards one side, what will happen? The patient starts experiencing nystagmus if he is having BPPV. Okay, the patient starts experiencing nystagmus if he is suffering from BPPV. Okay, so if nystagmus is present, definitely the diagnosis of BPPV will be done. Okay, this maneuver which is performed is called as the Dix-Hallpike maneuver. This maneuver which is performed is known as the Dix-Hallpike maneuver, which is used for diagnosis of BPPV in a patient. Okay, this is a previous year question. Image has also come. Next is this condition. What is this? Here you can see this is another maneuver which is used for treatment of BPPV. This is a 5-step maneuver which is done. It is not a 2-step. It is a 5 steps maneuver, and it is a cyclical maneuver which will keep on repeating itself. And here you can see there is no doctor or no examiner which is present. Okay, no doctor, because this is done by the patient himself. Okay, so here the patient is asked to turn his head and turn his position in various directions so that the otoconia or the otolith which are there, which went into the semicircular canal, they will come back and they will stick to the macula again, and the patient's condition or the patient's vertigo will stop. Okay, so that's the important thing. This is the treatment maneuver known as the Epley's maneuver. This is what is the treatment maneuver for BPPV known as the Epley's maneuver. So that is the differences, because in image a lot of people get confused. So now you don't need to get confused. Diagnosis के लिए only 2 steps and a non-cyclical maneuver with presence of doctor. But treatment के लिए 5 steps, cyclical maneuver without any doctor. Okay, so that's the important thing. Next, if I talk about, this is what is your IAC. What is IAC? Internal auditory canal, also known as your internal acoustic meatus. Now, in the IAC or internal auditory canal, usually it is a connection between the inner ear and the cranial cavity. Okay, so here definitely one nerve will come inside the inner ear, the other nerve will go inside the cranial cavity. And these 2 nerves which go inside the internal auditory canal is nothing but the 7th and the 8th cranial nerve. That is your facial nerve and the vestibulocochlear nerve respectively. Okay, so if I talk about this is the cross section or a cut section of your internal auditory canal. As you can see, it is divided into upper half and the lower half with the help of a bony crest known as the falciform crest. And it is divided, the upper half is divided into 2 halves further with the help of a bony septum called as the Bell's bar. So this has been asked, what is the septum called as? This septum in the internal auditory canal which divides the upper half into further 2 halves, it is known as the Bell's bar. Now there are these compartments. The first one you can see it is the facial nerve which is passing. Okay, so first compartment it is the facial nerve. Next is the first division of your vestibulocochlear nerve, and it is which division? Superior vestibular division. So vestibulocochlear nerve or your 8th cranial nerve, now it has 3 divisions. One is called as the superior vestibular nerve which passes beside the facial nerve. Beneath the superior vestibular division we have the inferior vestibular division which passes, inferior vestibular division. And then over here beneath the facial nerve we have the cochlear division which passes. We have the cochlear division. There are 3 divisions: superior vestibular, inferior vestibular and cochlear division of the 8th cranial nerve or the vestibulocochlear nerve. That has to be remembered. Okay. Now if I talk about audiology, what is audiology, guys? Audiology is nothing but study of hearing. And if the patient is having any hearing loss, you will perform an audiometric test which will tell you about the type of hearing loss in the patient. Okay, so the type of hearing loss in the patient can be of 2 types. Either it can be a conductive hearing loss where there is some problem in the conduction of the sound. And where does conduction of sound occurs? In the external or the middle ear. So if there is any problem in the external or the middle ear, the patient will have a conductive hearing loss. Whereas the patient will suffer from a sensory neural hearing loss if there is some problem in the inner ear or the 8th cranial nerve. Okay, if there is some problem in the 8th cranial nerve or the inner ear, the patient will suffer from a sensory neural hearing loss. Sensory hearing loss means problem in the inner ear, that is the cochlea. Neural hearing loss means problem in the 8th cranial nerve, that is your vestibulocochlear nerve. Okay, that's important. Now the first audiometric investigation or the audiologic investigation that we can see over here is the PTA. That is a pure tone audiometry, I have told you. And At the end of the PTA, you will get this graph, and this graph is what is called as the audiogram. This graph is known as the audiogram. Now, usually over here, you can see two lines on an audiogram. And what are these two lines? So the first line, you can see it is a dotted line, or it is represented by some brackets. This is what is called as bone conduction. When you keep the electrode over the mastoid of this patient, that is called as bone conduction. Okay. Next is what is a continuous line, or with close symbols it is represented like this. It is called as the air conduction. Okay. And definitely air conduction is when you keep the electrode in his external auditory canal. Okay. So that is what is the basic difference. Important is if the audiogram is having blue lines, it is suggestive of a left ear. Okay. If the audiogram has blue colored lines, that is suggestive of left ear. And if the audiogram has red lines, it is suggestive of a right ear. Okay, audiogram has red lines, it is suggestive of right ear. First audiogram that you can see, it is a normal audiogram. Why I will say it is a normal audiogram in this patient? Because you see this is the cutoff. This is 25 decibels. If the air conduction as well as the bone conduction, if the bone conduction and the air conduction, both of them are beneath 25 decibels. If both of them are less than 25 decibels, okay, air conduction as well as bone conduction, then we say that the patient is having a normal hearing, that the person is having a normal hearing. Next is over here, you can see that in this condition, the continuous line with crosses, that is air conduction, and this dotted line with brackets is the bone conduction. Important is you can see that this is the landmark, 25 decibels wala. The air conduction is definitely beyond 25 decibels. That means the air conduction of this patient is poor. Air conduction of this patient is poor. Whereas the bone conduction is beneath 25 decibels. So therefore the bone conduction of this patient is normal. And what you are able to see that between air conduction and bone conduction, there is a significant gap. And that significant gap is known as AB gap, which will be more than 15 decibels. Yes, more than 15 decibels of significant AB gap will be present. So if the air conduction is poor, bone conduction is normal, and AB gap is present, this is a case of conductive hearing loss. This is what is the case of conductive hearing loss. Next is the last one. Here you can see that both the lines, where it is bone conduction or it is air conduction, both of them are beneath 25 decibels or they are more than 25 decibels. That means here the bone conduction is also poor as well as the air conduction is also poor. So if both of them are poor, that means there is some problem in the factory itself. What is the factory? The inner ear or your eighth nerve. So that means the patient is suffering from a sensory neural hearing loss. Okay. So the problem is in the sensory neural, the patient is suffering from sensory neural hearing loss or SNHL. Okay. Next is this investigation. What do I mean by this investigation? You can see there are various electrodes in this child which are placed at various places, mainly over this area, on the occipital area. And what is beneath the occipital area? We have the brainstem over there. Okay. So definitely here we are trying to record the electrical activity in his brainstem. And this is what is called as BERA. What is BERA? BERA, therefore, brainstem evoked response audiometry. Okay, so it is brainstem evoked response audiometry. That means what are we trying to do? We are making the patient hear some sounds, but we are not asking the patient, ki, are you able to hear the sound? In PTA, we were asking the patient, ki, awaaz sunai di? Are you able to hear the sound? But in this condition, the patient's participation is not required. Why? Because we will not ask the patient whether you are able to hear the sound or what. We will directly record the electrical changes from his brainstem area. Why? What is located in the brainstem area? In the brainstem area, you have your auditory pathway. In the brainstem area, you have the auditory pathway. So you will directly record the electrical changes in the auditory pathway. Then you will be able to understand, okay, the patient is able to hear or not. Because if it is a small child, like a neonate, definitely he will not be able to participate in a pure tone audiometry. For that conditions, we will go for a BERA. Okay? Or he is a malingerer. Malingerer is whom? A person who lies. Usually a prisoner who tries to avoid any punishment in those patients. So BERA is usually used for screening of hearing in high-risk babies, in babies who are suffering from meningitis, or babies who are admitted in the NICU, not for normal neonates. Not for normal neonates usually. You can use if it is available, but otherwise for normal neonates, we have a cheaper technique which is available. BERA is somewhat expensive. Okay? So high risk meningitis NICU babies mein, and definitely in malingerers also. That means who are lying. In malingerers also. Okay? On BERA, definitely you will get how many waves? On BERA, you will get 7 waves. On BERA, you will get 7 waves. The most important wave of BERA or the largest wave of BERA is wave number 5. And this wave number 5 generates from which area of the auditory pathway? This wave number 5 is generated from the lateral lemniscus of the auditory pathway. It is generated from lateral lemniscus of the auditory pathway. That's the important thing. Whereas if I talk about next investigation, which is normally used in neonates, okay, in neonates for screening of hearing, that means whether a neonate is able to hear or not, because this has to be done in every neonate, every child who is born, we need to check for his hearing, if he is able to hear normally or not. So for screening of hearing in a normal neonate, if he is not high risk, if he is not admitted in the NICU, or if he is not suffering from meningitis, in all other normal neonates, the hearing screening investigation of choice is what is OAE. What is OAE? Autoacoustic emissions. Okay, what autoacoustic emission? What we were doing in BERA, we were giving sound to the ear of this patient and we were recording the electrical changes from his auditory pathway or from his brainstem area. But here, we will give sound to the ear of this patient and then we will record the echoes coming from the outer hair cells. Here we will be recording the echoes coming from the outer hair cells of cochlea. Okay, so that is what is done. It is more portable device, more cheaper, easily available. That's the reason why it is normally used. But if autoacoustic emission is not able to give you proper finding, then definitely go for a BERA, which is better one. Okay. Next is this one. What is this? This is a tympanometry. If I talk about tympanometry, what do we check on tympanometry? On tympanometry, we actually check for the freedom of movement of the tympanic membrane and the ear ossicles. Are the ear ossicles or the tympanic membrane able to move freely or not? Okay, that is usually checked with the help of a tympanometry. If I talk about tympanometry, so the first graph that you can see over here, it is this type A graph. Type A graph is usually, here you can see the ear ossicles or the tympanic membrane is not fixed also and it is not freely moving also. Okay, so this is a normal condition. Okay, so type A graph is usually seen in a normal person. Next, you can see that in this graph, the type AD graph which is there, you can see the tympanic membrane or the ear ossicles mainly. The ear ossicles are able to move freely because they are not connected to each other now anymore. So therefore, this type AD graph now, there is more movement of the ear ossicles. Why? Because they have been dislocated from each other now. So therefore, they are free. Okay? So type AD graph, D stands for ossicular dislocation. So type AD graph is usually seen in cases of ossicular dislocation. Next is, here you can see in this graph, definitely the ear ossicles are not able to move freely. Why they are not able to move freely? Because they are fixed. And what is that condition where the ear ossicle or the stapes becomes fixed? Definitely in a case of otosclerosis. Okay, we have discussed that. So in otosclerosis, we will see a AS graph. S stands for sclerosis over here. Okay. Next that you can see over here is this. It is the type B graph. As you can see, the type B graph is a flat graph completely. Okay. The type B graph is usually seen in two conditions. One is definitely the glue ear. Okay, where there was a lot of glue-like fluid inside the middle ear, that was glue ear. And second condition where you will see it is tympanic membrane perforation. So in tympanic membrane perforation also you will be able to see a type B or a flat curve or a flat graph. Whereas type C which is there now, this type C curve which is there over here, you can see this type C curve is usually on the negative side. Why negative side? Because the tympanic membrane is not coming outside, it is going inside. And when the tympanic membrane goes inside, whenever it is pulled inside, that is called as retraction of tympanic membrane. And when does the retraction of tympanic membrane occur? So this type C graph will be seen in cases of ET blockage. As we know, whenever the eustachian tube is blocked, definitely in middle ear there is a negative pressure which is created and that causes a retraction of tympanic membrane and therefore a type C graph on or a type C cover on tympanometry. Okay? Sure. That is important. Moving further. Okay. Next, if I talk about the auditory pathway, I hope all of you are quite aware about the auditory pathway. The mnemonic to remember the auditory pathway is E. coli Ma. Okay, these are the various parts of the auditory pathway. Cochlea is not a part of the auditory pathway. Cochlea is the sensory end organ responsible for hearing. Auditory pathway starts from here. It is the 8th nerve. So E stands for the 8th nerve, that is the vestibulocochlear nerve, which will carry the sensations from the cochlea further to the brain. Okay, that is your 8th nerve. Then C stands for what? C does not stand for cochlea, it stands for the cochlear nucleus. So C stands for the cochlear nucleus. Then O stands for what? O stands for superior olivary complex. Okay, O stands for superior olivary complex. Then I stands for what? L इसमें आता है बीच में. The L stands for lateral lemniscus. Okay, L usually stands for lateral lemniscus. Then I stands for the inferior colliculus. I usually stands for the inferior colliculus. Then there is M. M stands for the medial geniculate body. And lastly A. A stands for the auditory cortex. Okay, so that is important to be remembered. Please remember these are the important things. These are the auditory. This is the auditory pathway remembered by the mnemonic E. coli Ma. Okay. Now if I talk about this usually, what is this? this is an audiogram again. This is a pure tone audiometry which was performed. And on this audiogram, what you are able to see, there are blue lines. So this is the audiogram of which ear? This is the audiogram of left ear because it is blue lines. The dotted line that you can see, it is the bone conduction. The continuous line that you can see, it is the air conduction. Now you can see both of them are fine. Both of them are less than 25 decibels only. But at one side, what happens? At one side, definitely, you are able to see a dip in the air conduction as well as bone conduction. And what is that point? It is actually 4000 hertz. Okay. So in air conduction and air conduction and bone conduction, if you are able to see a dip at 4000 hertz, it is known as the acoustic dip. And where are we able to see this acoustic dip? Can anybody tell me? Acoustic dip on an audiogram in air conduction and bone conduction at 4000 hertz is usually seen in which condition? It is seen in which condition? Can anybody let me know that? Jaldi se batao. Acoustic dip in air conduction and bone conduction at 4000 hertz usually. It is seen in which condition, guys? It is seen in which condition? Anybody? At 2000 hertz, only a dip in bone conduction known as Carhart's notch that I've told you already. It is seen in cases of otosclerosis. But here, very good. It is seen in cases of NIHL, that is noise-induced hearing loss. Please remember, it is seen in cases of noise-induced hearing loss. Okay, so noise-induced hearing loss mein dikhta hai, we can see this acoustic dip. Okay, at 4000 hertz. Treatment for noise-induced hearing loss is usually a hearing aid itself. Next one is this. What you can see over here? You can see the patient is having a sloping audiogram. The patient is having a sloping audiogram. That means here in the early stages of the disease, the patient is actually having high frequency hearing loss. Okay, in the early stages of the disease, the patient is having high frequency hearing loss. As you can see, at higher frequencies, the patient is having a hearing loss. Okay, so that's the important thing. High frequency hearing loss is usually there in this patient in the early stages of the disease, and a sloping audiogram is achieved. Where is sloping audiogram seen? So please remember, sloping audiogram is usually seen in cases of presbyacusis. What is presbyacusis? Presbyacusis is nothing but age-induced hearing loss. So age-induced hearing loss is known as presbyacusis, and in that condition we are able to get a sloping audiogram where there is a high frequency hearing loss in early stages. Treatment is again a hearing aid. Important is they have asked you about this. What is this? This is the cochlea. Now there are two parts of the cochlea. One is called as the basal turn of cochlea. Important is basal turn of cochlea, if it is damaged, it will cause which kind of hearing loss? And this is what is the apex of cochlea. And if apex of cochlea is damaged, it will cause which type of hearing loss? That was a previous year question. So please remember, if the basal turn of cochlea is damaged, the patient will have, okay, if the basal turn of cochlea is damaged, the patient will have a high frequency hearing loss. The patient has a high frequency hearing loss. And if the apex of the cochlea is damaged, the patient will have a low frequency hearing loss. The patient will have a low frequency hearing loss. Okay? So that's the important thing. Next, if I talk about a condition that is called as acoustic neuroma. So what is a neuroma? So it is a tumor. It is a benign tumor which is arising from a nerve. Which nerve? Acoustic nerve. What is the acoustic nerve? The nerve responsible for hearing. And what is that nerve? So it is nothing but your 8th cranial nerve or your vestibulocochlear nerve. Okay. So it is actually a benign tumor arising from the 8th cranial nerve or your vestibulocochlear nerve. And what is the most common site? There were 3 divisions now of vestibulocochlear nerve: superior vestibular, inferior vestibular, and cochlear. The most common site for this tumor is actually the inferior vestibular division. It is the inferior vestibular branch of 8th cranial nerve. Okay? Important is, if they ask you, important, what is another name for your acoustic neuroma? It is also known as vestibular schwannoma. Another name for your 8th nerve tumor is also known as vestibular schwannoma. Please remember that. Okay? Now, what will be the complaint of the patient if the 8th nerve is damaged? As I've told you, if the 8th nerve is damaged, definitely the patient will have what? Hearing loss. Which kind of hearing loss? Sensory neural hearing loss. But here, this tumor is very slowly growing. Therefore, the patient will not have a sudden hearing loss. The patient will have a gradually progressive hearing loss. Like over years, the patient will develop a hearing loss. Okay? So the patient has a gradually progressive sensory neural hearing loss, and that too usually a unilateral. Why? Because it is a unilateral tumor except in one condition. And what is that condition? It is usually, so please remember, acoustic neuroma or vestibular schwannoma is usually unilateral, except in which condition? Answer me that. Okay, in which condition acoustic neuroma or vestibular schwannoma is bilateral? Answer me that in the chat box. Okay, so that is important, guys. Please remember this properly. Okay, the phenomena which can be seen in cases of acoustic neuroma. What happens? As the patient is not able to hear, we try to increase the intensity of our voice. We try to speak loudly. But when we try to speak loudly now, the patient could not even understand anything. So that means there will be the understanding of the speech falls further on increasing the intensity of sound. This is classically known as the rollover phenomena. This is classically known as the rollover phenomena, which is commonly seen in a case of acoustic neuroma or vestibular schwannoma. Apart from this, please remember the sign which is seen in cases of acoustic neuroma. Okay, that is known as the Hitzelberger sign. What is this Hitzelberger sign? So please remember, acoustic neuroma will not only involve the 8th cranial nerve. Yes, the most common cranial nerve which is involved is the 8th cranial nerve, followed by, okay, most common is 8th cranial nerve followed by the 5th cranial nerve. But apart from that, the 7th cranial nerve can also be involved at times. And which division of the 7th cranial nerve? The sensory division of the 7th cranial nerve. And that sensory division of 7th cranial nerve, as I've told you, it was known as nerve of Würzburg. So therefore, the nerve of Würzburg will be damaged, and that causes loss of sensations in the posterior superior part of external auditory canal. I told you now, in the posterior superior part of EAC, it was the nerve of Würzburg which was supplying. So if the nerve of Würzburg will be damaged, definitely the patient will have loss of sensations in the posterior superior part of EAC. That is what is called as the Hitzelberger sign. Very good, Karishma. It is only in cases of neurofibromatosis type 2 where you can see a bilateral acoustic neuroma. Otherwise, in all conditions, you are able to see a unilateral acoustic neuroma. Now, what is the investigation of choice? As it is a nerve tumor, anything arising from the nerve or neural tissue, always it should be a MRI. But here you need to highlight the tumor. Therefore, it should be a gadolinium enhanced MRI. So therefore, the investigation of choice is a gadolinium enhanced MRI. Okay. On this gadolinium enhanced MRI, you will be able to see this is the pons and this is the cerebellum. So at the cerebellopontine junction or at the cerebellopontine angle, this tumor will be seen. Rather, please remember, it is the most common cerebellopontine angle tumor. Yes, acoustic neuroma is the most common cerebellopontine angle tumor. And which kind of appearance is seen? You can see this classically gives, the MRI classically gives the ice cream cone appearance. The MRI classically gives the ice cream cone appearance. What is the treatment in this condition? The treatment is nothing but surgical excision. The treatment is nothing but surgical excision. Okay, that's important. Next, if I talk about a question, what does question states? A young male complains of episodes of tinnitus. Tinnitus is what? Ringing sensation in the ear. वो बोलेगा डॉक्टर साहब साय साय की आवाज आती है. Along with that, the patient will have vertigo. Along with that, there will be hearing loss. Each episode which is there in the patient, it usually lasts for a span of 24 hours. एक दिन तक चलते ये symptoms and then it goes off. The pure tone audiometry has been given below. What is the diagnosis? What does the pure tone audiometry shows you? The pure tone audiometry shows that there is a rising audiogram over here. This is a case of rising audiogram. Make the diagnosis. Answer me in the chat box. What is the diagnosis? There is a rising audiogram. Sloping audiogram was seen in cases of presbyacusis or age-induced hearing loss. Whereas rising audiogram is seen in this condition. What is seen over here? In the earlier stages of the disease, the patient has low frequency hearing loss. In the earlier stages of the disease, the apex of the cochlea is damaged initially and therefore the patient has a low frequency hearing loss. Okay? So rising audiogram is a feature. Along with that, it is the episodic disease where the patient is having episodes of tinnitus, classical triad, tinnitus, vertigo and hearing loss. Okay? This is the classical triad of the disease, definitely. And each episode will last for around 24 hours, just like migraine. What is the diagnosis? It usually is seen in males. Commonly it is seen in males in the 3rd or 4th decade of life. It is commonly seen in males in the 3rd or 4th decade of life. Why does this happen? Let me tell you that first. Okay, then you will make a diagnosis. Very good. So important is, why does this happen? Now I told you, in the inner ear or in the membranous inner ear, the fluid which was present was called as the endolymph. Okay, this endolymph was produced by the stria vascularis and it was absorbed by the endolymphatic sac. It was absorbed by the endolymphatic sac. But what if the endolymphatic sac is not able to absorb this endolymph? If the endolymphatic sac is not able to absorb this endolymph, what will happen? The amount of endolymph will keep on rising. The amount of endolymph will keep on rising in the inner ear, and that will cause increased pressure inside the inner ear. This excessive pressure inside the inner ear will cause damage to the inner ear. It will cause damage mainly to the cochlea or to the other structures as well. That is the reason why the patient will have hearing loss as well as vertigo. Okay? So that is what is seen, and this is a case of Meniere's disease. So it looks like a condition in eye. What was that condition in eye when the intraocular pressure was rising? That was glaucoma, right? Therefore, this condition is also known as glaucoma of ear, also known as endolymphatic hydrops. Why? Because the endolymphatic sac is not able to absorb the endolymph properly, due to which the level of endolymph rises, the pressure rises, and that causes damage to the cochlea. And this condition is nothing else but the Meniere's disease. So this is a case of Meniere's disease, definitely. Okay, this is the diagnosis of Meniere's disease usually. Okay. If I talk about Meniere's disease, what are the phenomena usually seen? As I've told you, it is episodic disease. Three important features makes up the triad of Meniere's disease. It is more commonly seen in males in third or fourth decade of life. Each episode of the disease will only last for 24 hours. Phenomena which will be seen, one will be called as the recruitment phenomena. What is the recruitment phenomena? Here the patient hates to go to the noisy areas. Why? Because in noisy areas the loud sound appears more loud to this patient. जो loud sound होगा ना वो और ज़्यादा जोर से सुनाई देगा. So the loud sound appears more loud. That is what is recruitment phenomena. Next, the patient will have Tullio's phenomena. What is Tullio's phenomena? The patient will experience vertigo whenever he hears a loud sound. जब भी वो जोर की आवाज सुनता है उसको चक्कर आने लगते हैं. Okay, whenever the patient hears a loud sound, he experiences vertigo. That is the Tullio's phenomena. And the last one is what is the Tumarkin's crisis. What happens during an episode of Meniere's disease? The patient will fall down, but he is not unconscious. Without turning unconscious, the patient falls down. बेहोश नहीं हुआ है, but still the patient falls down during an episode. That is what is Tumarkin's crisis. As I've told you, on investigation, pure tone audiometry will show you this rising audiogram, because in initial stages of the disease, there is damage only to the apex. So therefore, low frequency hearing loss will be there. If I ask you what is the investigation of choice for Meniere's disease, answer should be electrocochleography. Yes, you will check the electric stimulus in the cases of cochlea. Okay, so electrocochleography, and if this is there, so that will be a better answer. But that is glycerol test. So electrocochleography plus glycerol test is considered investigation of choice. If you need to answer it as the single best, then answer definitely should be electrocochleography. Then your answer definitely should be electrocochleography. Okay? That's important. If I talk about the treatment, during a patient, what is the major complaint of the patient? During an episode of Meniere's disease, the major complaint of the patient is vertigo. That's the reason why if a patient comes to you in an episode of Meniere's, you need to give anti-vertigo drugs to the patient. And anti-vertigo drugs usually which are given, it can be drugs like prochlorperazine vagara. Okay, cinnarizine, prochlorperazine, all of these drugs. But in between the episodes, now when you are discharging the patient, you are sending the patient home. In between the episodes now, what we need to do? We need to decrease the pressure inside the inner ear. And how we are going to decrease the pressure inside inner ear? By giving the patient carbonic anhydrase inhibitors. These carbonic anhydrase inhibitors which are given to the patient, these are drugs like tablet of acetazolamide should be given. Okay, tablet of acetazolamide should be given to the patient. That will help in decreasing the pressure. Next, if the patient is having a lot of damage now, the patient is not only having episodes, but in between the episodes also, now the patient is experiencing hearing loss. In this condition, you need to check whether the patient has any residual hearing or not. If the patient has residual hearing, go for a better surgery called as a endolymphatic sac decompression surgery. If residual hearing is present, that means he is still able to hear with that affected ear. Then go for an endolymphatic sac decompression surgery. Go for a endolymphatic sac decompression surgery. And what is the surgical landmark for that endolymphatic sac? The surgical landmark for that endolymphatic sac is nothing else but the Donaldson's line. Okay? But if residual hearing is absent, that means the patient is not able to hear anything with the affected ear. Then definitely it's better to kill the affected ear. And killing of affected ear is called as chemical ablation. Okay? So we will go for a chemical ablation of inner ear. That means killing of inner ear by injecting some chemical inside it. And what is that chemical? It is actually a drug. That drug we directly inject into the inner ear. That causes complete damage of the cochlea. That is nothing but gentamicin. So we will give a trans-tympanic injection of gentamicin inside the inside the inner ear, which will completely kill the inner ear. That is also called as chemical ablation of inner ear. Okay? So that is important to be remembered. The last disease that I would like to talk about is what is called as glomus tympanicum. Okay, glomus tympanicum is nothing else. Tympanicum means middle ear. Okay, this was the term that was used in the recent examination, and a lot of people, even they were aware that this is a case of glomus jugulare, but they were not able to answer. Why? Because the term which was used was glomus tympanicum. It was not the glomus jugulare, which is the usual term. Okay, so glomus tympanicum is nothing but another name for glomus jugulare. It is another name that is used for glomus jugulare, guys. Please remember that. It is another name which is used for glomus jugulare. Okay, that is important. And what happens over here, as I've told you now, this. Beneath the floor of the middle ear, we have the jugular bulb. Around the jugular bulb, we have these small cells. And what are these small cells called as? These cells are called as the glomus cells. So if there is a tumor, which arises from this glomus cells, okay, what will happen? That tumor which arises from the glomus cells around the jugular bulb is what is called as a glomus jugulare or a glomus tympanicum. Why it is called as glomus tympanicum? Because you can see this tumor will invade the floor of the middle ear. It will invade the floor of middle ear and it will grow inside the middle ear. In the lower part of the middle ear, it will grow, and therefore it is also called as glomus tympanicum. Okay? So that's the important thing usually you need to remember, guys. So glomus jugulare or glomus tympanicum, it is nothing but a tumor which arises. It is a benign tumor, please remember. Yes, it is benign. You will say, sir, how it is damaging the floor or inferior wall of the middle ear? Because though it is benign, it is locally invasive. Okay, so it is a benign but a locally invasive tumor arising from. It is a benign but a locally invasive tumor arising from the glomus cells. And where are these glomus cells lying? Glomus cells lying around the jugular bulb. Okay, glomus cells lying around the jugular bulb. Okay, that is the thing. Now, what will be the complaint of the patient usually? What will be the complaint of the patient? When this tumor will grow inside the middle ear of this patient. When this tumor will grow inside the middle ear of this patient, the patient will come to you with complaints of conductive hearing loss. The patient comes to you with complaints of conductive hearing loss, and on otoscopic examination, you will be able to see such sign. Why? Because this is a tumor which arises from the blood vessel now. Therefore, it will be bright red in color. And as you can see, this tumor is coming from the floor of the middle ear, and therefore it looks like a rising sun. And that is what is called as a rising sun sign. When this tumor erodes or damages the floor of the middle ear and grows in the lower part of the middle ear, then on otoscopic examination, it will be seen as a rising sun sign definitely. Okay? So that will be seen. No issues with this, anybody? Whereas, apart from this, the patient will also have a pulsatile tinnitus. That means as it is a vessel now, the patient will be able to hear the pulsations of this vessel in the ear. That is called as a pulsatile tinnitus. And what will happen? The tumor then will also damage, or it will also cause erosion of the tympanic membrane, and then it will grow inside the external auditory canal. And then the patient will come to you with a red bleeding mass. Then the patient can come to you with a red bleeding mass. If they ask you now, what is where it is common? So please remember, glomus jugulare or glomus tympanicum is more common in females usually. It is more common in females. What is the investigation of choice? So as it is a vascular tumor, we know in cases of vascular tumors, what is contraindicated? In cases of any vascular tumor, definitely biopsy is absolutely contraindicated because the patient can lead to death. The patient can bleed to death on the OT table itself. Therefore, the investigation of choice is a CCT, a contrast enhanced CT scan. And on contrast enhanced CT scan, you will be able to see this classical sign. You can see there is erosion of this bony septum between the carotid canal and the jugular foramen. This erosion of bony septum is classically known as the Phelps sign. This is classically known as the Phelps sign. So on CCT, you are able to see a Phelps sign in cases of glomus jugulare. Please remember that. What is done for treatment? So here also, though it is a vascular tumor, treatment is again a surgical excision. So you will say, sir, will the patient not bleed to death? So we have discussed in juvenile nasopharyngeal angiofibroma also. There also the treatment of choice was surgical excision. But to prevent bleeding during surgery, we were doing a pre-operative embolization. So here also in this condition, we will go for a pre-operative embolization as well. Okay? Next is this. What is this? This is a normal hearing aid. And what is the function of a hearing aid? So this is a classical hearing aid, and this is the most commonly used hearing aid. It is also called as behind the ear hearing aid. It is also known as behind the ear hearing aid, which is most commonly used as well. The function of hearing aid is nothing but amplification of the sound. Function of hearing aid is nothing but amplification of the sound. Please remember. Okay, it will just amplify or increase the intensity of the sound. Okay, and it is usually given in a patient of hearing loss. In which kinds of hearing loss? Usually you can give it in mild hearing loss, in moderate hearing loss, in severe hearing loss, but not in cases of profound hearing loss. How much is profound hearing loss, guys? So please remember, profound hearing loss is usually more than 90 decibels of hearing loss. If a patient is having more than 90 decibels of hearing loss, that is called as a profound hearing loss. Please remember that. Okay? So in that condition, hearing aid is of no use. So what is done in cases of profound hearing loss then? So therefore, in a case of profound hearing loss, in cases of bilateral profound hearing loss, we will go for a surgery. And what is that surgery which is done for bilateral profound hearing loss? It is this surgery where we are going to implant this machine inside the cochlea, or we are going to implant this electrode inside the cochlea. This is what is called as the cochlear implant surgery. It is known as the cochlear implant surgery. What is the, okay, important is where is this electrode placed, in which part of the cochlea. So if I draw this cut section of cochlea, this is the membranous cochlea, also known as scala media. This part is called as scala vestibuli, and this called as scala tympani. So therefore the electrode is actually placed in the lower part, in the scala tympani. Please remember. So the electrode which is there in a case of cochlear implant surgery, it is usually placed within the scala tympani. That was a previous year question. Where is the electrode of cochlear implant placed? So the electrode is placed within the scala tympani, and what will this electrode do? The electrode will stimulate the cochlea directly, and therefore the patient can hear better. Okay? So it is only done in cases of bilateral profound hearing loss. But important is, what is the prerequisite, or what is the condition, what is the prerequisite for performing a cochlear implant surgery? The prerequisite or the condition is that the 8th nerve of this patient should be normal. The 8th nerve of this patient should be normal. Why? Because if you are stimulating the cochlea, the stimulus will be further carried by the 8th nerve. तुम cochlea को तो stimulate कर रहे हो, but अगर उसकी 8th nerve खराब है, वो आगे impulse जाएगी क्या? नहीं जाती. So that is the problem. So if the 8th nerve is damaged, cochlear implant surgery is of no use. So that's the important. What is the condition of cochlear implant surgery? That the 8th nerve should be normal. But in cases of a bilateral acoustic neuroma, and where is bilateral acoustic neuroma seen? Bilateral acoustic neuroma is what? In both the 8th nerve there is a tumor. Bilateral acoustic neuroma is only seen in a case of neurofibromatosis type 2. In that condition, in bilateral acoustic neuroma, we know that the 8th nerve has been damaged. And if the 8th nerve has been damaged, can we use a cochlear implant surgery? No, because it needs a normal 8th nerve. So if the cochlea, or if the vestibular cochlear nerve, the 8th nerve has been damaged, then we need to go for this procedure. And what is this procedure called as? This is the ABI, that is the auditory brainstem implant. This is what is known as the ABI, known as auditory brainstem implant. So here, the electrode, as you can see over here, this electrode will not stimulate the cochlea. The electrode which is there now, it will directly stimulate the brainstem. And where is the electrode placed? That was another question. So here the electrode placed is directly in the brainstem. In which part of the brainstem is it placed? It is placed in the lateral recess of 4th ventricle. So in cases of auditory brainstem implant, the electrode is directly placed in the lateral recess of 4th ventricle. That's important to be remembered. So here there is direct stimulation of the brainstem. There is direct stimulation of the brainstem. That's what occurs in cases of auditory brainstem implant, which is used in cases of bilateral acoustic neuroma when both the 8 nerves have been damaged, and that is usually seen in cases of neurofibromatosis type 2. The next one, you can see there is no wire over here. There is directly a screw which is fixed to the occipital bone, and we fix a implant to that occipital bone. This is what is called as BAHA. This type of hearing aid is known as BAHA, that is a bone anchored hearing aid. This is known as a bone anchored hearing aid. When do we use a bone anchored hearing aid? So usually for a normal hearing aid, for every hearing aid you see that the pinna is required, right? The pinna is required for the machine. But if the pinna is not there, can you use these other types of hearing aids? No. So therefore, in a case of anoxia, if the pinna is completely absent, or in a case of microtia, that means the pinna is small and very underdeveloped, okay? Or in a case of EAC, external auditory canal, stenosis and atresia. Okay, external auditory canal अगर stenosis and narrowing हो चुकी है उसकी, या फिर there is atresia, absence of EAC. In these conditions, you need to use a BAHA, bone anchored hearing aid. What is this instrument now? This instrument is what is called as otoscope. This is known as otoscope. I have told you about a lot now. Otoscopic examination. This is what is otoscope. This is the nozzle which goes inside the external auditory canal. This is the magnifying lens which will help us magnify the EAC and the tympanic membrane. And here we have the switch for the light source. Okay. Then what is this? This is actually a Siegel speculum. I told you in fistula test, we use a Siegel speculum. This is what is the Siegel speculum. The question was, what are the functions of Siegel speculum? Again, this part goes inside the external auditory canal. This is the magnifying lens, and this is the bulb which can be used to change air pressure inside the external auditory canal. So it is used to change air pressure. Okay, it is used to change air pressure inside the EAC. Okay. Next important, it is used for magnification, as you can see. Okay, it is used for magnification as well. Third, you can fill up antibiotic powder into this, and then you can spray it in the external auditory canal. So yes, it is also used to spray antibiotic powder in the EAC. It is also used to spray antibiotic powder in the external auditory canal. And it is important used for two tests. One, as I've told you, it is used for the fistula test, which is positive in a case of labyrinthine fistula. And second, it is also used for Gillis test, which is done in a case of otosclerosis. Okay? These are the uses, because one of the options was all of the following are the uses of Seagull speculum except. So the option was removal of foreign body. Seagull speculum is never used for removal of the foreign body. And the last topic that I want to conclude with is the one where there were two questions this time, and that is what is called as the facial nerve palsy. If I talk about facial nerve palsy, facial nerve is nothing else but the seventh cranial nerve, and we know that the facial nerve will enter into the inner ear via the internal auditory canal. Okay, and it will exit the inner ear, it will exit the ear via this stylomastoid foramen over here. Okay, this facial nerve palsy can occur due to trauma usually. Okay, facial nerve palsy usually occurs due to head trauma. Okay, it usually occurs due to head trauma, and there can be two types of facial nerve palsy after a head trauma. Yes, either the patient will have immediate onset facial nerve palsy. That means when the patient was brought to emergency, he was having features of facial nerve palsy. That is the immediate onset. The cause for this is actually a fracture, and therefore the treatment in this should be a surgical repair. Okay, the treatment should be a surgical repair in this case. But other condition will be the patient did not have any features of facial nerve palsy at the time of presentation in the emergency. Emergency में कोई दिक्कत नहीं थी. But when the patient was discharged after 1 week or so, the patient comes to you with features of facial nerve palsy. That is called as a delayed onset facial nerve palsy. The cause for this is edema. Yes, due to trauma there would have been inflammation, and due to inflammation there is edema, and this edema or swelling compresses the facial nerve, which leads to facial nerve palsy. For this the treatment should be steroids. For this the treatment should be steroids, which will help in reducing the edema. Okay? Next important is one of the types of facial nerve palsy, and that is Bell's palsy. So a lot of people are still confused that Bell's palsy is facial palsy. No, facial nerve palsy is a broader term. It can be due to any cause. Bell's palsy is a subtype of facial nerve palsy. And what is Bell's palsy, guys? So please remember, Bell's palsy is usually idiopathic. That means unknown cause, sudden onset. Okay, sudden onset. अचानक से हो जाती है, sudden onset. Lower motor neuron facial palsy. Okay, it is a idiopathic, sudden onset, lower motor neuron facial palsy. That is what is Bell's palsy. And this was the question, that Bell's palsy is upper motor neuron or lower motor neuron facial palsy. You need to remember it is a lower motor neuron facial palsy. There is injury to the facial nerve outside the brain. Okay? So that is important. In Bell's palsy or in facial nerve palsy, what will be the features in the patient? The patient will have something like this. If my right-sided facial nerve is paralyzed or damaged, I will have drooping of mouth. I will have drooping of mouth on the right side or on the affected side. Or there will be deviation of mouth towards the normal side. So either of that you can remember. Either there will be drooping of mouth. Either there will be drooping of mouth on the affected side, or there will be deviation on the normal side. Okay? Apart from this, the patient will have what? There will be loss of wrinkles. Yes, as it is a lower motor neuron facial palsy, there will be loss of wrinkles on the forehead, only on the affected side. That is, on my right side, there will be loss of wrinkles. I will not have any wrinkles. Okay? Loss of wrinkles on forehead, only on the affected side again. That is only seen in a lower motor neuron facial palsy. It is not a feature of upper motor neuron. Upper motor neuron mein loss of wrinkling will not be seen. Apart from this, when the patient will try to close the eye, on affected side, the patient is not able to close the eye completely. Why? Because this facial muscle known as orbicularis oculi, this orbicularis oculi closes the eye. Now this is innervated by the facial nerve, and we know the facial nerve of this patient has been damaged. Therefore, this orbicularis oculi muscle has been paralyzed. Therefore, when the patient tries to close the eye is still open, and that is what is called as lag of thalamus. That is what is known as lag of thalamus. Due to this lag of thalamus, you can see some part of his eye will be constantly exposed to the external environment. Therefore, anything, kachra jo aata hai, all the debris from the external environment can cause inflammation of its cornea, and that is what is called as exposure keratitis. The patient will have exposure keratitis as well. Okay? All of these features will be there in the patient of facial nerve palsy or Bell's palsy. No issues with this. Now, what is usually caused? Initially, it is considered to be idiopathic, but some studies say that HSV1 infection, that is herpes simplex virus 1 infection, have been seen as a cause in most of the Bell's palsy, but still it is idiopathic, which is more common. Okay? So therefore, what should be the treatment? Because infection usually causes inflammation, and inflammation leads to edema, and that edema causes compression of the facial nerve, which leads to facial palsy. Okay? So therefore, to decrease the edema, the drug of choice for facial nerve palsy, which is there, the drug of choice for facial nerve palsy is usually oral steroids. Okay, it is definitely oral steroids. And along with oral steroids, if we are suspecting herpes simplex virus infection, definitely we can also give acyclovir to the patient. Okay, and this are given for a span of 3 weeks to the patient. These are given for a span of 3 weeks. But even after 3 weeks, the patient's condition does not improve. Even after 3 weeks, the patient's condition fails. Then important, a lot of people directly mark surgical decompression. No, please remember, first you need to check now whether the facial nerve has been damaged or not. So if even 3 weeks of steroid therapy fails, then go for a test that is called as electrophysiological nerve testing. That is what is known as electrophysiological nerve testing. Okay? And after electrophysiological nerve testing, if you see that the facial nerve fibers have been damaged, then go for a surgical decompression of the nerve. Then go for a surgical decompression of the nerve. Okay, bring out the nerve of the fallopian canal or the bony canal. Okay, and it is mostly the labyrinthine segment, which is the narrowest segment of the facial nerve, which is compressed most of the times. Okay, that has to be done. Important is, there is another condition where the child had chicken pox, okay, in the childhood, but now the patient is coming to you usually in adulthood. He's an immunocompromised patient now, and now the patient is having painful ear vesicles. The patient is having painful vesicles in the ear. Okay, the patient is having painful ear vesicles. Painful ear vesicles are there. Okay, there are painful vesicles inside the ear usually. Along with that, the patient is also having features of facial palsy. Along with that, the patient is also having features of facial palsy. Other cranial nerves can also be involved at times, but most common is the facial nerve. What is this condition called as? So usually, as the child was having chickenpox in the childhood, it is caused by which virus? It is caused by the varicella zoster virus, that is human herpes virus type 3. Okay, now this varicella zoster virus which was there now, it remained in an inactive form or the dormant form in the dorsal root ganglion for a longer period of time. But when the patient's immunity dropped, what happened? This varicella zoster virus got a chance and it causes replication. It got activated, and due to that, what happened? Now there is again formation of these ear vesicles which are really painful in his external ear. Along with that, the patient has developed facial palsy. This is a case of herpes zoster oticus. This is a case of herpes zoster oticus. When this herpes zoster virus reactivates in this region, that is called as herpes zoster ophthalmicus. When it reactivates in certain dermatome, that is called as shingles. But this is a case of herpes zoster oticus, also known as Witt syndrome. This is also known as Ramsay-Hunt syndrome, and that was another question which has been asked in recent FMG exam. And what is the treatment of choice for Ramsay-Hunt syndrome? Definitely here you need to give oral acyclovir. Here definitely the treatment of choice will be oral acyclovir, because again it is a herpes virus. In very high doses like 800 mg, 4 to 5 times a day should be given. Okay? Thank you so much. That was all about your ENT, and all the best for your examinations. I hope all of you come out with flying colors. Important is, remember this message of mine, that stay strong, your test will become your testimony and your mess will become your message. But wait for that day, and for that day you definitely need to work hard. Okay, you have the last 2 months remaining in your hands. Start practicing a lot of MCQs now along with the revisions, and please give grand tests as well. A lot of people don't give grand tests. They are afraid of grand tests. Please start giving grand tests, because that will help you analyze where you are standing actually. Okay, so then at the end of the grand test you can analyze which subjects are weak, and definitely you can focus more on them because you have enough time in hand. So please don't let that time go in waste. Okay, so just focus on your weaker subjects. Definitely work hard, revise twice or thrice. Okay, whatever is possible for you. 2 revisions are minimum, otherwise it won't be possible at all. Practice a lot of MCQs, read their explanations properly. Otherwise, only practicing number of MCQs is not enough. Qualitative MCQ practice is better than a quantitative one. Okay, so that is what is required. Thank you so much, and let's meet in the next session. Thank you so much. Take care. Good night.